and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations, and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with
morning, everyone. It is wonderful to be able to see all the friends in the room. Welcome to day 2 of the 14th National Research Conference. Thank you so much for joining us. Today promises to be full of insightful research discussions. And we want to be able to open this morning with prayer, and so we want to ask Ms. Songa Parchment, she's the Executive Secretary in Policy Planning and Development, to be able to open in prayer. Ms. Parchment?
Good morning. Let's pray. Dear Heavenly Father, we come before you today with hearts full of gratitude for life and the opportunity you have given us to gather at this 14th Annual National Health Research Conference. We thank you for the minds and talents that you have blessed each of us with, enabling us to pursue knowledge and understanding of your creation. Oh God, as we engage in the pursuit of scientific discovery and innovation, we ask for your wisdom and guidance to be with us. Grant us clarity of thought, mind, insight, and understanding as we share and discuss the various research and ideas. May our discussion be filled with respect, open-mindedness, and a genuine desire for the betterment of Jamaica and the world at large. Oh God, you are omnipotent, omnipresent, omniscient. So we ask that your presence be felt in a special and unusual way today. God, bless each participant, presenter, and organizer with patience and perseverance. Help us to uphold the values of integrity, honesty, and humility in our pursuit. May our efforts contribute to the well-being of humanity and the flourishing of the world around us that is in such turmoil. Mighty God, we pray for fruitful discussion, meaningful connection, and a spirit of camaraderie among all participants. May this conference be a stepping stone for future advancements in science, leading to solutions for the challenges facing our world. God, we just thank you for this beautiful day that you have put us, and your words declare that we're to rejoice and be glad in it. Have your way in this conference today. We pray all of this in Jesus' mighty name. Amen. Amen.
Amen. Thank you so much, Ms. Parchment. Now it is time for our featured presentation, and it is my pleasure today to be able to present to you our Permanent Secretary, Dunstan Bryan. P.S. Bryan's presentation is around the use of technology in public health, and I'm craving your attention as I present his introduction. So Mr. Bryan joined the team of the Ministry of Health and Wellness as Permanent Secretary in November of 2018, bringing with him a wealth of knowledge and experience from working with the local public sector as well as with international development partners such as the World Bank and the Inter-American Development Bank for more than 2 decades. Mr. Bryan holds a master's degree in public policy and governance, a bachelor's in management studies, and a diploma in sociology, all from the University of the West Indies. Among his varied skill set is the ability to manage large, multi-skilled, problematic, that's mine, not theirs, multi-skilled teams with output-based methodologies and the development of monitoring and evaluation structures, processes, and framework for effective assessment of outputs, outcomes, and impacts. Dunstan Bryan has been instrumental in spearheading several of the structural and cultural transformation projects in the ministry, to include the ministry's full-scale adaptation of the performance management system, among others. Ladies and gentlemen, please help me to welcome our Permanent Secretary, Mr. Dunstan Brown.
Thank you very much, Moderator, the Principal Director for Corporate Services in the Ministry of Health and Wellness. I also wish to greet my colleagues here, especially Dr. Webster Carr, our Chief Epidemiologist, and the other conference coordinators. And thank you very much for the work that you have done to bring this conference once again to the hearts and minds of the many varied stakeholders that we have in health. So what I'm about to present to you today is an assessment that was done that looks at the different administrative approaches for the delivery of diagnostic imaging across the island. And what we set out to do in this presentation is outlined there. I won't go through it for the interest of time, but I want to point out some limitations to the research that we did in terms of the assessment, that the leasing arrangement that we have that we are about to assess, there's no similar leasing arrangement that is being proposed for the Caribbean, and therefore there's not any real points of comparison. Proprietorship on information for the proposal that we got regarding leasing kind of restricted our ability to deep dive into some data points that we have. There is limited availability of usage rates in hospitals for some of the equipment that we use, and so we had to make some assumptions, and given this paucity of information, we had to go to industry best practice. And sometimes these industry best practice are in our more developed countries in North America, etc. And so they may not have the same application to us here in the Caribbean, albeit in Jamaica. Now, there are three types of administrative mechanisms for the delivery of this service. We can outsource, which is what we're doing now, where we have a public-private partnership with the private sector, and the private sector would then provide these diagnostic imaging services for us. Right now, under a special vehicle project that we can have a lot of data from that. We can purchase the diagnostic equipment and we can operate these diagnostic equipment in our facilities, or we can lease. And leasing is a process where the equipment comes to us. We operate the equipment, but the equipment is owned and operated by the supplier of the goods. And it's owned and operated and maintained, owned and maintained by the private supplier. But we operate the system. So we're talking about, what are we talking about here? We're talking about CT scans, MRIs, ultrasounds, etc. Those imaging diagnostic tools that we use in hospital from time to time. Now, the Health Facilities Maintenance Unit did an assessment of our infrastructure in 2020 in terms of what type of diagnostic equipment we have, and it is some startling findings that we see here, where 53% were either fairly functional or non-functional. And immediately that goes to a service delivery issue for the availability of these diagnostic. And this particular issue arose when we did the analysis on bed stay time and length of stay in hospital. And it was found that because diagnostic services were so delayed, the length of time the patient stays on the bed becomes extended. Because the length of time is extended, the turnover rate on that bed is compromised. Because the turnover rate is compromised, then we have overcrowding in hospital. So there is a correlation and even a more direct causation between what we're seeing here and what we're seeing in terms of what our overcrowding statistics year on year. Maintenance was a major issue. There is no maintenance regime around our equipment or MRI machines. We have none. Well, one, is it up? I'm not so sure if it's up at KPH. I'd have to check. But the CT scans are also a major issue. I think we only have 2 operational CT scans in the entire health system, 2 of which are at the University Hospital of the West Indies, and we just brought up one at KPH. So we have a major issue when it comes on to the investments that we have made in this particular area. And this is coming out of a research assessment that was done by the team at HFMU in 2020. We received an unsolicited proposal from a private firm, and the unsolicited proposal sought to present to us an opportunity for a leasing arrangement. And the leasing arrangement had those 5 areas outlined there. Equipment, they would provide us with CT scan, X-ray, MRI, ultrasound, and mammography. Installation, maintenance, training, and of course the ICT infrastructure, because a lot of these investments require ICT infrastructure now, because those are the things that drive the innovation around the technology. The proposal also sought to have a monthly leasing cost of $706,000 over per month over 7 years. Very, very expensive, and it's 174 pieces of equipment in the categories outlined there that would provide it, along with the other services. So, but we have in our midst a project that we are doing. It is the Enhanced Healthcare Service Delivery Project, and that project is an outsourcing project, and that project gives us a lot of information, a lot of data around our usage pattern for different imaging services. And so we could use this project as a proxy for what this usage pattern is within our health facilities across the island. And so this project allowed us to assess what was happening in our health facilities. And what did we find? 65% of the tests done were CT, 13% were MRI under the project, 16% ultrasound, and 5% were other types of diagnostic tests. But when we deep dive into the type of facilities, which is our type A, B, C, and our specialist facilities, we recognize that the majority of the CTs, the majority of the hospitals use CTs as their main source of diagnostic imaging. So if you look on the total, you'll see that 65% of the total diagnostics that are done is CT. But when we look at our type B and our type C hospitals, we see that for the type B hospitals, it is 78% that is used in CTs. So of all the diagnostics that are requested from Enhanced Healthcare Project, in type B, 75% of it is in CTs. Okay? When you look at our type A, which is Cornwall and to a large extent Cornwall and KPH, only 53%, but that is to be nuanced by the fact that at the time, I think there was a partial functioning of KPH's CT, and so you may have that causing some sort of nuance. But if you look the fact that 23% for KPH and CRH is the MRI services. But when we now go over to the other side of the slide there on my right, your left, your right as well. And we compare the quantity to the cost, we realize that although CT is significant in terms of its cost, its quantity, its cost is comparable to other services. So while CTs are used a lot, the limited number of MRIs, it's very expensive to use MRIs. MRIs are far more expensive than CTs when we look at that. So what are we comparing? So we are looking at the assessment to look at the different options. And the three options, as I had outlined: outsourcing, purchasing by ourselves, and leasing. Those are the three. So we're comparing what the proposal came from the firm, the leasing that we have, and then some information on international best practice for if we own the equipment ourselves. And what we did in terms of a methodology, in terms of bringing everyone to the same space, is what we call a unit cost analysis. What was the unit cost to deliver a CT if you purchased? What was the unit cost for delivering a CT if you outsourced it? And what was the unit cost for delivering a CT if you purchased, outsourced, or leased it? And then we look at a discounted cash flow. That is, when you put in some financial variables and some economic variables, and for like your discount rates and your discount rates based on inflation, etc., to see if those prices held over time. Because we are now comparing like with like, and so because we are comparing like with like, we're looking at 7 years that was proposed in the lease agreement for 7 years if we bought it, or 7 years if we did outsourcing. So because we had to do some, as I said before, we didn't have a lot of information, we had to look at some assumptions, and there are a lot of assumptions. We had to make assumptions around what is the cost of maintenance, operational costs. So if we own the material, if we own the equipment ourselves and we're operating it ourselves, what are the costs associated with maintenance, operation, staffing? All of those costs were lumped into the equipment in terms of time, value, and all sort of other assumptions. And then we brought it down to a comprehensive cost, and then we used the usage rate from the Enhanced Healthcare Project to compare all three. So we said the volumes of CTs that we had in any 1 year would apply if you had done it, if you had purchased it yourself with the same volume, or if you had leased it, it would be the same volume. So all three were compared to that proxy that was provided by the Enhanced Healthcare Project. So the total cost, as we went through the different variables, the total cost plus, and time don't allow me to go through all of the assumptions that we made and all of the things that we looked into. But just to say that unit cost is the variable cost plus the fixed cost over the total units produced. So what was the variable cost for giving an example, what's the variable cost of maintenance? What's the variable cost for purchase? We'd have to look at maintenance costs, which can vary over time. And as a matter of fact, it does. So when you first purchase a piece of equipment, the maintenance cost is low. But over years, industry standards tell you that the maintenance cost moves as you move from routine maintenance into specific type of maintenance and replacement. And so you had to put in those values in there. The fixed cost would be the fixed cost of actually making the investment if you're purchasing. So we add the variable cost, so other costs that you'd have to add is salaries and allowances, overtime. All of those variables were put into the formula to get your variable cost. And then the total unit cost is how many tests were done. CTs, for example. So the unit cost analysis was done for each one of the variables: lease, purchase, and outsource. And what did we find? As you'll see from the graph here, and the top one is the totals, when we compare the totals of unit costs over 7 years, leasing was the most expensive. So it cost us $1,000, and this is all in US dollars, right? It's going to cost us $1,167 to produce all of the tests. And for leasing. For purchasing, it is $714 per test, and on average, and $754 if we outsource. The information that we have here, it changes for one particular year, and that is the year 23-24. And why did it change in 23-24? And I should move that from 23-24 to year 2. So take out the 23-24 and just say year 2. So you have year 1, 2022, and 2023, year 2, year 3, year 4. And for year 2, it changed because year 2 is when we are buying the equipment. So the cost, unit costs, changes in year 2 because that's when you're making all of your capital investment, right? And so that is why that orange line for purchase looks so expensive, because the unit costs in year 2, because you're making that capital outlay, is going to be that much more expensive. So overall, unit cost provided by all three service leasing is the most expensive method, being 39% more expensive than purchasing and 55% more expensive than outsourcing. When we went down to deep diving, we see where CTs, leasing is 7% more expensive than outsourcing and 54% more expensive than purchasing. So for CTs, the value proposition looks different. And for MRI, leasing is 47% more expensive than outsourcing and 19% more expensive than purchasing. So what does that say to you? If you look at the whole picture, leasing might seem to be a very bad proposition. But when you look at CTs and MRIs, it is not as egregious as we think. And of course, we did the discounted cash flow to test over time whether or not the value proposition held. If you now include some indicators for inflation and in terms of interest rates and interest rate movement, etc. And what did we find? We found that the value proposition held, that leasing was the most expensive, with a total discounted cash flow over the 7 years of some $50 million US. Versus if you purchase it yourself, $28 million, and if you outsource, $39 million. So, what do we get from that? There's an obvious achievement of, let me go to robustness test. And the robustness test is a method of validating your discounted cash flow analysis. And the robustness test, we use a discount rate of 7.5%, given where the interest rate was at the time, and it held. It found that there was this leasing being the least in there. However, we did not put into this calculation the cost of downtime of equipment because you don't have maintenance. We did not put into this assessment the availability of staff to manage equipment across the island. We did not put into this assessment a new culture because the current operational standard, and that's my word, I probably not the right word to use, but the current operational is that type C hospitals are not supposed to have CT scans. That's what I understand from it. But if you look at the analysis, a lot of the CTs that are being asked for is from type C hospitals. Yeah? So how do we begin to look at staffing and delivering those services in type C hospitals and those costs associated with that? So there's a need to put that we need to build out some sort of infrastructure, whether or not we lease, we buy, or we outsource. Or no, we lease or we buy, because outsources is too expensive. Leasing, bad, but outsourcing is so expensive. And when we did the qualitative assessment, which I have not put in this part of the study, when we did the qualitative assessment, one of the leading issues around the outsourcing is that the amount of time it takes it with ambulances to move the patient from the facility to the outsourcing place. And it compromises service delivery, especially when you have acutely ill patients who need these diagnostics but cannot be moved. All right? And so there's a quality of care issue that arises with outsourcing that makes it impractical. However, the value proposition, although from a cost perspective, leasing is not as viable as purchasing, we have to have the conversation around what does this mean for maintenance, and can we maintain an investment of CTs, MRIs, ultrasound, mammography, all of those types of equipment if we are not maintaining the infrastructure. And thank you. Did I make the time?
Thank you so much, P.S. We are going to open the floor for some comments and questions now. I am sure the PS is dying to explain some more of those details. So let's start over here with Dr. I'm sorry. Can you allow him to get a mic? Can you give the PS a mic as well?
Thank you.
Morning again, everyone. Dr. Dawkins Wright from the Ministry of Health and Wellness, Emergency Disaster Management and Special Services. Mike? Thank you very much, Permanent Secretary. I really do appreciate the kind of information shared from the quality of care perspective in particular. And I am happy that you went to the point of the issue of the human resource elements and the transportation aspect of it. I had two questions initially from the first part in terms of how the data was assessed. And I'm wondering why we lumped fairly functioning and non-functioning in the proportion in terms of the evaluation. And I wondered if that could be broken out a little bit more in terms of the status of affairs of our equipment in facilities. And the second thing that I'm particularly interested in is in the consideration for decision making. We tend to compare all imaging services, generally speaking. From the point of care perspective, ultrasound is very, very human resource dependent. And so it may not, I'm curious if we probably should take ultrasound out separately because of the implication and because of the high level of subjectivity in the reporting required for clinical decision-making purposes. And I think ultrasound needs to be treated a little bit differently because it's a little more difficult to compare and transfer across the system, because it depends a lot on the radiologist or in terms of interpretation and from the clinician's perspective, what to do with the information. And so some clinicians are sometimes a lot more selective in who they choose to conduct ultrasound. So I would probably treat that a little bit differently based on how it's utilized. And the other aspect of it in terms of the decision making, whilst it's unfortunate that we have taken a little while to classify our facilities based on the services offered, because clinical management guidelines has now placed CT as a basic imaging study, and so we need to get there in terms of what is considered basic requirements. And so that needs to be factored or weighted a little bit more in terms of the decision-making process and how we treat with same, and how do we get from the consideration with respect to MRIs, because that's still dependent, again, on the clinical management guidelines that's available to facilities. MRI, apart from probably some services like my good friend orthopedics, MRI, use of MRI will vary across the country. And so comparing utilization across the country may be challenging to interpret because it depends a lot on the familiarity of the clinicians in the utilization of MRI in management practices.
Okay. All right. Yes.
If I may.
All right, thank you very, very much for those questions, Doctor. I thank you for your reflections, but the issue of the disaggregation of the information between the type of equipment fairly functional and functional, I accept that, and I think we can do that disaggregation. I think there's another study assessment that is being done by HFMU now to see where we are at this point in time, which I'm sure will show an even more severe condition. In terms of ultrasound and the treatment, remember now I'm coming strictly from an administrative perspective and I am looking at quantities and the usage rate of quantities. So I haven't done any analysis because I'm just looking at costing analysis. So if I were now to turn this study over into a sort of qualitative interpretation of the information and you do your qualitative methodologies, I'm sure some of that information, but this is just a quick secondary analysis based on secondary data provided by the different documents that we received in the ministry and using international benchmarks based on, again, secondary data. The CT scan as a basic imaging service, I agree, and the evidence is there from Enhance that the physicians have already begun to use it as a basic tool for their diagnosis. However, our management protocols still say, and I can be corrected, but from the best of my knowledge, that CTs are not supposed to be available. And if, well, fair. But even in the recent Human Resource for Health for physician, the physician workforce document that was produced by the ministry, it said that CT services would be provided in Type C hospitals that are the only hospitals in the parish. That's what it says. So the building out of those radiologists and the radiographers and all of those technical staff that are required to deliver that service will only be built out in those facilities, Type C facilities that are the only Type C facilities. So that would be St. Thomas in Princess Margaret, Hanover, Portland, those Type C facilities that are the only ones there. So that's what, but based on the information that we have, it seems as if it needs to be available in all Type C facilities.
Sorry. The other aspect to give consideration to is where we are going in terms of our developmental plan and the aspect of the availability of remote involvement of specialists.
Right.
And what's the term? Telemedicine capabilities, etc. CT allows for more optimal utilization because then, whilst our human resource for health plan will speak to radiologists, if that capability is built out, we are better able to realize the capacity that we need, because we can then now depend on a very remote located radiologist, but keep radiographers a lot more, which is on our books already, and we can build that out and retain and more speedily attain the capacity that we need to manage the patient in the field and reduce the need for transfers. Because that's really the decision-making point for the Type Cs.
Yeah, and I completely agree, Dr. Dawkins, right? And with our limitations in HR, we have to look to technology, and that telemedicine approach has been seen to be very effective. As a matter of fact, one or two of the private entities in Jamaica have their diagnostics read in India and not in Jamaica.
Okay. Thank you, Dr. Dawkins. I think we had another question. All right. Hold on, nurse. Go ahead, sir. You can introduce yourself and just start your question.
Good morning, everybody. Dr. Derek McDowell, orthopedic surgeon, St. Ansbury Regional Hospital. Mr. Permanent Secretary, happy to meet you again.
Long time, doctor.
Long time, sir. Yes. Yeah, I listened keenly to your presentation, and what concerns me is, or I won't say concern, but it's something in my head. The maintenance of the equipment that you plan to put into the hospitals. There's a biomedical department in every single hospital, and the maintenance of a lot of this equipment with the varying technology, the changing technology, is left to them. And it would, for it to be adequately maintained, to mean that the individuals in the biomedical department would have to be trained. And wherever the equipment comes from, whether it be China, whether it be India, North America, and they'll have to be following up on all this kind of thing. Right. And I'm wondering if maintenance contracts from the companies probably would be a better idea, because it's with the same kind of cost. And when the equipment comes in, it works great for 6 months. Mm-hmm. But you miss the first maintenance schedule, it goes off, and we become frustrated. And then the patients come in and start making demands, and you say, well, the equipment is not working. The biomedical department goes in, they do their diagnostics, and sometimes they do make a mess of it, to be honest with you. And the equipment gets messed up, it doesn't work. It comes to end of life long before the manufacturer stated it should. And I mean, I can give you examples, I don't want to embarrass anybody, but that has been the reality. Mm-hmm. And I'm wondering if, probably could be controversial, if we shouldn't disband the biomedical departments and get maintenance contracts from a company that supply the equipment, and that might be an idea. Or make the biomedical people do something different, but not touch brand new equipment with the varying technologies that change yearly every 6 months.
Yeah.
Question.
I mean, it's a valid point, doctor. We don't even have to go to MRIs and CT. We can look at the cancer, the LINAC, and what a very poor story the LINAC is. This LINAC costs some $8 million US, plus the cost to install it. And if I should cost the downtime of the LINAC, I believe that in any 1 year the LINAC has been down more than 20% of the time. And if we cost also the impact on treatment for patients with cancer, we will begin to see how astronomical that lack of investment is. Now, I take the point, but I don't think it's necessary to eliminate or discard or to abolish the units. What I think we need to do is to, as a policy, remember now we launched the maintenance policy for the government of Jamaica. As the policy outlines, there is supposed to be a training component to each one of these investments that we make. So once we buy a piece of equipment, there's supposed to be training. Two, the contracts now insist that we must have a maintenance agreement along with the contract. So the units will only be doing, the biomedical units won't be doing routine maintenance. So we taught how to do routine maintenance. If there's something outside of routine that happens to the equipment, it is the responsibility of the company to address it. And then three, this is why leasing is so viable as an option, because when you lease, that's no longer your problem. Within the lease agreement, you would then have a standard that says the downtime to the equipment shouldn't be no longer than 3 days. And if it goes over 3 days, there's a penalty in contract that the company pays for having downtime being like that. So there are different options that we need to look at. The internal deficiencies that we have, we need to cost them more more than what we have done here to show why purchasing equipment, there's never going to be, and once you have somebody in biomedical person, suitably trained, they become very attractive and they leave because they are paid far more than we will ever be able to pay them.
May I just say something? I don't want to belabor the point, but part of the problem is this, that in procuring the equipment, you get three proposals. And in any one unit, let's say for example, my unit, I may have 10 different equipment from 10 different companies. And the problem is when, okay, so you have routine maintenance every 3 months. The problem is when somebody steps in at 1 month to diagnose something and they just mess up everything. They mess up everything. So come 6 months, you hear that you shouldn't have done this because so and so and so and so.
You avoid the warranty.
And you avoid the warranty. Yeah. Mm-hmm. That's what happens. And you have 10 different bits of equipment. 8 stop working with it 8 months. And, you know, what do you do? And the biomedical person, I think it's impossible for 5 people in the department to go to 10 different companies to be trained adequately to even diagnose a problem in a machine.
No, absolutely, doctor. And that's part of the conversation that we need to have.
And I just want to say this. For example, a vital bit of equipment we have at Senabe, a CM, for example, has come to end of life at 5 years, when it should be about 10 years.
Yeah.
And it's just not working now. And we have a backup of patients, and, you know, it's a problem.
Yeah.
We agree. Go ahead, nurse.
All right, so good morning again, colleagues, and thank you, PS. I love that presentation. I'm happy that Ministry of Health is doing that level of analysis and looking at how we can problem solve. But I'd like to go back to ultrasounds. Ultrasounds are basic, I think basic test services that we should have in obstetrics and gynecology. And from experience, I realize that for the smaller health facilities, like the type Cs, sometimes these are not available. And so, as you mentioned, some tests not being available can impact quality of care. And so that's an area that I'd like for the ministry to look at. What is available in our type C facilities that don't have the specialist? And so if we have the ultrasound machine with the persons who can do the test and identify issues early, then we can respond in a timely manner. So that's an area that I'd like for us to look at what is available for obstetrics and gynae in our more remote facilities and what we need to put in to assist with service delivery.
Accepted. Okay. I think that's a beautiful recommendation.
So we have some questions online. Here's a mic.
It's an online question, right?
Right.
Yeah.
Excellent presentation. I've been listening very carefully, and one of the questions, PS, was why is ultrasound not readily available and accessible as being the very, very first line of diagnostic tool? But the colleague who just asked a question and made a recommendation a while ago would have addressed that. Now, in issue of training, as it relates to the equipment that we have, I believe that we should train more rather than 1 or 2. And in training as well, we could, as a nation, begin to invest in the population. We have students who are willing to be trained as it relates to radiography, radiology, and teaching them side by side this high-end equipment that we will love to have in our nation. And more also, PS, we will also be glad if incorporating this teaching to enhance a continuous,
Go ahead.
to enhance a continuous supply. That is to say, you're not waiting for one or few to be let go, and then you are left with nobody else to manage or repair or take charge of the equipment. We keep supplying. That is to say, we have enough personnel. All right?
Yes, and thank you for that, that reflection, because you're absolutely right, and our human resource for health strategy is supposed to move us there, where we train enough for the local market as well as for the market in terms of those persons who will migrate, because we can't stop. We have always been a migratory community and society, and so migration has been a part of our history for many, 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 many years. So that is part of our human resource for health, and so we have to look all the way back to our secondary schools and what is the product coming out of our secondary schools that enable us to have that critical mass of persons available to be trained by our universities for these specialist skills. But your point is one that is part of our policy direction and our strategy going forward.
Thank you so much, PS. All right, I believe that that's the end of the question period. If it is that you are burning, with a question, we can entertain that conversation outside of the session, but I believe that we have a time constraint. So we want to be able to say thank you again for your participation, and thank you so much to the Permanent Secretary, who you can see is using science for decision making. Thank you so much.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have...
Good morning, everyone. At this point in time, we want to express our appreciation to our executive management, to our permanent secretary for his presentation this morning. I think it generated a lot of discussion, and we thank you very much that the PS has come and supported this event. And we hope, as one of the persons who gave questions has said, that this will be a standard for the ministry in doing this type of research. So we want to congratulate the Permanent Secretary in terms of showcasing this excellent research that is going on. So thank you very much, PS. Thank you. We also wish to thank our Chief Technical Director. No. Principal Director of Corporate Services, Mrs. Spencer Smith, and we want to thank her for taking us through the session and moderating the questions very ably. So thank you very much, Mrs. Spencer Smith.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablet. Yes, you should. We need physical activity.
Well, that's what adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health.
Oh, I heard it will improve memory and overall mood.
Yes, it will maintain our weight and lowers the risk for the pressure.
Do you know what will lower your risk of depression?
What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now, we're gonna do the basic step. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees. Hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
So come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu. Plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Do your part to prevent mosquito breeding. Mosquitoes will breed in any container that holds water.
Tightly cover water storage containers such as drums, barrels, buckets and tanks. If this cannot be done, pour cooking oil on the water surface. Punch holes in all tins, plastics and beverage boxes to prevent the collection of water before disposal. Cover all tires or fill with dirt to prevent water collection. Scrub all vases once per week to remove mosquito eggs. Use mosquito repellents to protect yourself from mosquito bites. Dispose of garbage properly by placing in plastic bags and securing properly to prevent water collection.
A message from the Ministry of Health and Wellness.
Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy. Better get up. Physical activity help your mood and memory, make you remember anything. Cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something. Yeah man, listen young youth. Physical activity, healthier weight, go and exercise. Students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents. Physical activity is of the essence. Needed like full stop in any sentence. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Love your body, treat your body right. Love your body, treat your body right.
The Ministry of Health and Wellness is celebrating Caribbean Wellness Day 2023 with a weekend of wellness. Saturday, September 9. All roads lead to the University of Technology Jamaica for a sweat fest 4 p.m. to 8 p.m. Join the 3K Fun Run Walk, pass through the obstacle course, and work up a sweat with the Sweet Energy Fitness team. Admission free! No sign-up required. Lots of prizes and surprises along with free food samples. Come, get your Jamaica Moves shirt. It's a weekend of wellness. Wow, with the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Protect yourself from the bite of this mosquito.
A message from the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Search for its breeding sites and destroy them.
A message from the Ministry of Health and Wellness.
Good ganja sense, learn more your ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Knowledge is power, youths we need that. Ganja smoking and no pitney thing that. Commercial ganja you farm then you reap. Entrepreneurs and scientists see. Good ganja sense, learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Be smart with your ganja, go get a permit. Ganja full of uses, make sure you learn it. Can sell eye drops, it make for eyes. Ganja can boost lives. Good ganja sense, good ganja sense. Learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis.
Brought to you by the National Council on Drug Abuse, an agency of the Ministry of Health and Wellness.
We got to be careful when using pesticides.
All right, Richie. Can I come out to mash up some spraying idea?
Yeah, I go spray them corn there.
So, are the three wearing the protective gear?
Why the sun too hot for suit up here, man?
So you'd read the label before you start. Wear protective gears. Goggles.
Okay, good morning, everybody. It's that time now for us to start this session on application of technology in public health. I'm Dr. Bradley Edwards, and I must apologize for this late arrival. I missed the time. But I wouldn't want to miss this session for the world, because it is a session that is dear and special to me. It's about the application of technology in health in general, and that is something I'm very excited about. Our first speaker today is Mr. Cameron Bennett. He's currently the project manager for the GIS Transformation Unit at the Kingston and St. Andrew Health Department. He's a graduate from the University of Technology. He has served as Environmental Health Officer in the British Virgin Islands and Public Health Inspector in Kingston and St. Andrew Health Department. Cameron's dedication to transparency and accessibility in technology underscores his commitment to innovation and efficiency in the field of public health, where he consistently makes a significant impact. And his topic today is harnessing geographic information systems for advancing environmental health, a case study from the public health inspectors of the Kingston and St. Andrew Health Department in Jamaica. Looking forward to hearing what our speaker, Mr. Bennett, has to say about this. I'm sure just keep your ears open, keep your minds open. We have a lot to learn from him. Thanks.
All right, thank you, Mr. Moderator. Want to
thank everybody for being here. And it's a pleasure to present part of our ongoing research that's being carried out. Well, it's not really research, it's a project that we're implementing in the Kingston and St. Andrew Health Department. All right, as was said, the topic is harnessing geographic information systems for advancing environmental health. It's an ongoing project, so it's a case study that's being carried out in the Kingston and St. Andrew Health Department. All right, so as we know, Kingston and St. Andrew has a population of about 667,000 persons, as according to the 2011 census. And the projections are to be over 1.2 million as of 2023 to 2025. So we understand that this provides a significant challenge for the Kingston and St. Andrew Health Department in carrying out efficient and effective food safety monitoring within the parishes. Now, the Kingston and St. Andrew Health Department is charged with the responsibility of administering the health needs of approximately 30% of Jamaica's population. So we can understand that the implications that comes with that. KSA actually is one of the most densely populated areas in the English-speaking Caribbean. So we understand the food safety challenges and the environmental health challenges that come along with that. KSA is responsible, the Kingston and St. Andrew Health Department is responsible for administering the health needs and requirements of both parishes. So, what our project sought to address, the challenges the project sought to address is, first and foremost, the absence of a central food safety monitoring database in the department. This was done, almost still is being done with paper. I mean, this is the 21st century, we want to move away from that. We also wanted to apply GIS technology to addressing the challenges faced by the food safety portfolio. We also wanted to address the lack of access the public health inspectors had to real-time food establishment data while they were carrying out their inspections. In addition to that, there was a slow turnaround, well, there still is, slow turnaround for establishment, licensing and inspection and follow-up and so on. And we understand the implications of that. We have a duty as the public health officers to ensure that we respect the turnaround time. I mean, people are paying for the licenses, so we need to respond in a timely manner. We also wanted to produce accurate and timely reports. We also wanted to allow for real-time access to historical inspection data. Rather than going to an establishment, the environmental health officer could just now check the historical inspection data from a central database. We also wanted to carry out trend analyses to drive informed decision-making. We also wanted to provide a robust tool to aid in the carrying out of inspections and strengthen the capacity of the health department to plan and facilitate food safety intervention programs. Now, having established the existence of the problems, we set out on mapping the food establishments and the food establishment licensing process. We wanted to know where bottlenecks were, where we could work out efficiency measures that would improve the way the system serves the public. In addition to that, we set about digitizing the existing food inspection instrument. As it stands, it's a book that is done, the forms are filled out in triplicate. One is left with the proprietor, another is left with the officer, and one is sent into the department. Also, we carried out digital entry and archiving of past food inspection forms. So all of the inspections that were done before now, we wanted to digitize the results, have them stored in a database for real-time access. Also, verification and sanitization of establishment and inspection data was also carried out. Now, what are some of the technology that we used? For the database, we actually worked with MySQL, it's an industry standard database management system. The maps were actually OpenStreetMaps, Google Maps API using things like Leaflet and so on. The programming or what controlled the logic of the system was handled by PHP and JavaScript, and it was all built on top of a Laravel framework. The framework was chosen due to the fact that the Southeast Regional Health Authority would have had other applications running on the same framework, so we wanted to increase uniformity So if there's an issue, if one of us decided that we were to up and leave, as the PS mentioned earlier, we're a migratory society, there wouldn't be challenges with getting somebody in who would understand what framework it was built on. Now, this is a map. This is what the officer would see when he or she gets a tablet, goes out into the field to do the inspection. The green would show those establishments that are certified, those who would have been licensed. The red shows those who are expired, and the yellow ones are the ones who are soon to be expired within either 30 or 60 days. So that guides us into resource allocation, knowing which establishments we need to address first. So typically we would go to the red ones since they're expired, and it's illegal to operate a food handling establishment without a license. And the yellow ones, we would send out notifications for them to remind them that they would need to come up and carry the license. Now, this is the establishment profile page. Those blue boxes were actually the person's name we had to block out. So at the top, we notice there's a map with the establishment location. Next, this allows for directions to be sent to the user's phone. That's a public health inspector's phone. I mean, if there is some rural location that we can't really find the directions, we can use the directions API that Google Maps allows for. So the next, in the middle, we have the establishment demographic data. Displays data such as the operator name, expiry date, food establishment licenses, phone, email for notification purposes, etc. And the one that is closest to my heart is what we see at the bottom. That's the establishment inspection history. Back in the day, the public health officer would have to either acquire, however, the past inspection forms, but now what we can, or they sometimes would have to ask the proprietor if they had the previous inspection forms, which kind of looked a little unprofessional if you asked me. So what we did, we had the previous inspections in the database, so all the officer would need to do is click on the view details at the last inspection. If it is a revisit, we would know exactly where we would need to check. So that kind of cut down the inspection time significantly. Now, this is a snippet of the database. So this is, it shows the geographic coordinates, it shows the ID number and all the relevant information. So this is actually a MySQL screenshot. Now, PHIs were equipped in order to carry data collection with tablet computers that they did carry out the food inspections with. The data is uploaded in real time to the Central Food Safety Database, where users with the requisite privileges, like a supervisor, for example, can access and view that data in real time. That has implications on things like establishment closures. Rather than the officer having to get back to the office to get the closure notices, if a closure is implemented, it flags the supervisor. They can double check and prepare the closure notices so the officer can go ahead and implement it. Food establishments can be spatially represented on the map, where on-the-spot analysis of the data can be carried out. So this is an example of some of the data analysis tools that we have. So there are graphs that shows the inspection types within the past 3 months, whether it's a compliance. Compliance is in response to an application for licensing. A routine, which is, as the name suggests, routine inspections. Reinspection is an inspection that follows up a previous inspection, whether routine, compliance, complaint, etc. It also gives you a breakdown of the parish status, which is some of the most important data that we collect, where we know which establishments are expired, how many, establishments are expired, which are certified, and so on. And it also shows inspection trends over a period of time. So the additional analysis tools will also be implemented through feedback and focus groups, since it's ongoing. So there are more things we need to add and implement. So we're going to finish up an analytics page. This will feature the charts, more in-depth analysis, and a reports page. I mean, as a public health inspector, the monthly report is a bane of every public health inspector's existence. It is a tedious process. We have to go through all of the paperwork, all of the diary, and we have to collate, and it takes a while. We typically have to take an entire day to put together the presentation, the report. So The goal is to just click a button, save a PDF, send it off to the supervisor. That's the goal. That's one of the many goals. So, ethical consideration. And on the course of the project, there arose certain ethical queries such as what's the data used for, which data is collected. So the data that's collected is only data that is relevant to the public health inspection, to the inspection. So officer consent was also sought before they were given tablets and so on. So the results, what were some of the results? The first month we carried out field testing. We noticed subsequent to that month a 62% increase in inspections. The previous month had 191. The subsequent month, that's October, had 309 inspections. We had immediate access to inspection results. The data analytics helped so much in turnaround time and execution of the recommendations. What was most noteworthy as far as I'm concerned is the enthusiasm with which the officers adopted the tool. I mean, officers asked me as recently as yesterday when we can fling with the inspection book. I mean, it's tedious, it's cumbersome, and I see with them, but it's a process. So, in conclusion, food inspections are carried out in a more efficient manner, faster as when compared to before. Decisions made, interventions implemented are more data-driven rather than having to check on what was there before and so on. We just look at the system, check the data that's there, and we can act accordingly. One other thing we noticed was the faster turnaround time for applications and revisits. So that one is pretty much one of the selling points. PHIs are now able to conduct inspection with the guidance of historical data in a more efficient manner. Food establishments are brought up to compliance at a faster rate. We noticed that. That's one of the more profound things that we noticed. Real-time communication between field workers and central databases for quick response to potential food safety issues. So we can check trends to probably arrest any potential food safety issues that may arise. So we want to also include predictive modeling in the system, and we also want to implement an alert system that notifies relevant authorities and stakeholders in real time when potential food safety issues are detected. We also want to implement seamless data sharing and communication between health departments, agencies, and other relevant organizations. So it is going to reach a time where the minister would not necessarily need to say, call the local health department for food safety data. We also plan to implement the system in other areas of public health like vector control and so on. So that's the end of my presentation. And first of all, I would like to give a special thanks to the Southeast Regional Health Authority. They would have facilitated this project. The Kingston and St. Andrew Health Department, which would have hosted the unit, and the forward-thinking nature to want to apply technology to improve how the delivery of environmental health activities. Also, the public health inspectorate, I'm a public health inspector, could not have carried this out without the cooperation of the inspectors in the Kingston and St. Andrew Health Department. So if anybody wants to contact us, the contact information is there. We are hosted at the Comprehensive Health Center. That's the Slipen Road Comprehensive Health Center, 55 Slipen Road. And we are open to other technology-related, GIS-related projects, because what we are currently in the process of working on something surrounding the current dengue outbreak. All right, ladies and gentlemen, thank you very much.
Wow, that was efficient and very stimulating. I want to big up Kingston and St. Andrew Health Department and the Southeast Regional Health Authority for allowing this innovative and creative thing. And Mr. Bennett, really excellent work, and we really want to commend the team. We'll be asking some questions towards the end, so please store your questions, reserve your questions so you can ask. And I'm just going to introduce our next speaker, who is Ms. Keisha Barwise. Let me get my thing going here. All right. So Keisha is known to me online, actually. We've done a lot of training together in terms of the electronic health record systems that have been coming to Jamaica and the various layers of it. We've had input from Australia, and different things. But Keisha has always been there, a little squeaky voice. I've seen her in real life now. And I just want to congratulate Keisha for all the work she's been doing behind the scenes. But let me just give you a little information about her. She is a health informatician who has made a profound impact in the healthcare sector. Her transformative work spans various dimensions, including her role in advancing standardized data collection practices and the National Digital Health Interoperability Platform, bolstering the information architecture of the Ministry of Health and Wellness. Her professional efforts and leadership have left a lasting mark on the information architecture of the Ministry of Health and Wellness. Her additional training in health informatics underscores her commitment to bridging healthcare and technology, embodying the fusion of academic acumen, practical wisdom, and a relentless pursuit of excellence. Based on the work that Keisha and the team has done, I'm sure that we can listen to what she has to say on this particular topic today. And the topic she'll be speaking about is the leveraging standardized local clinical knowledge for enhanced healthcare delivery through health technology. I can't wait to hear what she has to say. But I just give her a hand as she comes forward.
Good morning, everyone. Thank you, Dr. Edwards. So I'm Dr. Keisha Barwise, and I'm really excited to be here this morning to share with you about the work that we've been doing and give you some insight into the My Health platform proof of concept. It's an initiative by the Ministry of Health and Wellness, PAHO, the IDB, and the European Union. The primary objective of the platform is to offer care teams a real-time comprehensive view of patients' records, ensuring access to the right data at the right time, and we hope to elevate the quality of care that we're able to offer to our patients. The authors of the abstract were Dr. Michelle Ruth, Senior Director, Information Systems for Health, Mr. Jermaine Martin, Director of Health Record Services, Dr. Carol Holland, Health Informatics and Data Governance Consultant with PAHO, and I worked as a health informatics consultant on the Health System Strengthening Program for the prevention and care management of non-communicable diseases. If you want to find out more about the work that we've been doing, you can take a quick shot of that QR code, and I'll go right ahead. So, of course, we want to focus on the transformative potential of integrating our local clinical knowledge into our information systems. Using the Information Systems for Health framework that is championed by the Pan American Health Organization, we have been emphasizing data management and communication technologies, evidence-based decisions, health analysis, innovation, and access to information, learning, and sharing. And we've undertaken capacity building in the areas of data standards, quality, and governance, particularly using the Open Air or Open EHR specification, which I'll talk about a little bit later. So we have taken the focus of focusing on data and not applications because we want to ensure the quality of the data that we have. And of course, we want to eventually have data that will help us not only to take over our patients, but to help us make management decisions, public health management, improvement of our processes, and of course, health research. But in order to do that, we need to make sure that we start with good data. A lot of times in the common way that we do things, we end up spending a lot of time after the fact having to process and clean this data. But if we start with good data, we can eliminate or lessen that step. So we decided to look at two databases. We know that currently most of our healthcare currently is still very analog. But even as we're moving towards digitizing and using more electronic systems, a lot of the electronic systems that currently do exist do not talk with each other and are unable to share information. And this means a lot of times we duplicate the information that we're collecting because these systems aren't able to share information. So we looked at these two databases and we found some inconsistencies with the data that was collected. A lot of the data, of course, is collected free text. And because of that, it's subject to some interpretation of how somebody might represent a particular clinical concept or a particular term. And we decided to do this integration exercise, but we wanted to make sure that we understood the data. So we spoke with subject matter experts in the area. We spoke with staff from the Family Health Services Unit. We spoke with staff from the National Public Health Lab to understand how they use the data. And then we translated that and combined it with international knowledge to create a consistent and reproducible or reusable artifact. We also did some work with identity management and using vocabulary to standardize how we store this information. So what is Open EHR or Open Air? And it's a standard that's globally curated by clinicians that allows us to capture complex patient data. It separates the data from the application, and we have similar clinical concepts being stored together, which help to facilitate analysis. And it also operates from the perspective of collecting the data once, high-quality data, and being able to use it for many purposes. SNOMED CT stands for the Systematized Nomenclature of Medicine Clinical Terms. And it was created in 1967 in the United States. It is now a global, multilingual clinical vocabulary with over 360,000 clinical terms. It allows a specific, detailed documentation of all of these areas that you see here. And it also automatically allows for the interpretation of each of these terms. And of course, this holds powerful potential for research and analytics. So looking here is just a breakdown of hypertensive disorder, hypertension. You will never see this in a clinical interface. You don't need to worry about the codes, but this is just to show you what happens behind the scenes when you look at a particular clinical term. So if you notice in the blue area, we have all of the synonyms for hypertension. So if you entered any of those into the clinical system, it would know you're talking about hypertension. It also has relationships with other terms in the terminology, both parents and children. This is not the exhaustive list of children, but it just shows you the kind of detail that you can capture in a clinical system for a particular clinical term. Further delving into hypertensive disorder, if you look at this breakdown, you can see the layers of meaning that are incorporated into this single term. So just by having the term hypertensive disorder or hypertension, we know that it's a disorder of the cardiovascular system. We know that the particular body structure that is involved is a systemic circulatory system, that it's a cardiovascular measurement or found by a cardiovascular measurement. That cardiovascular measurement is blood pressure, and it's interpreted when that value is increased. And all of that is included in that single term. So we incorporated all of this knowledge that we gained from the local professionals that we spoke to create the My Health platform. And though this front end that will serve both patients and providers is probably easily reproducible in terms of what it looks like, the engineering that goes behind it ensures that we have secure, accurate, real-time data for treating our patients for research and innovation. We also did some work as well using the ISO standard for the collection of demographic information to consistently represent how we're going to capture this data. And we're exploring the use of a national identifier for health to help us to be able to track our patients as they cross various points of care. And currently we have the NPHL and ComCare COVID-19 databases included. The data that you're looking at is real. The patient's name is not, of course, because you have to protect our patient's privacy. And going further, we would want to add data from other electronic systems, data such as patient encounters and discharge summaries, medications, e-prescribing, labs and imaging, and also patient-reported data, such as data from the Jamaica Moves app that was created locally with a local developer / Roots. And we can also build other applications, including data entry on the platform. So some of the lessons that we learned included the importance of owning our data, of clearly documenting how we want to use our data and how we want to capture our data, which we can use to give to software developers as they make applications to serve us, the importance of identity management to ensure the veracity and accuracy of all people who interact with the healthcare system, both patients and providers. Also, to the importance of standardizing how we collect the data. Yeah. So we want to thank you so much for listening. And we also want to thank all our partners that have worked with us to get us to this point. Of course, again, if you're interested to find out more about the work that we're doing with the My Health platform, you can reach out to me on LinkedIn at kbarwise or by the QR code. Thank you so much for your time.
Thank you, Dr. Barwise. Please don't feel in a way that if you don't understand exactly what you were saying, it takes a while. I did have training with them for months, and as she was speaking now that it started to come to me. But it's all very important. It is essential that we understand the workings of what's going behind the scene. It works. That's all we need to really know, that it really works. Again, reserve your questions for later. And we are about to hear now from Dr. Derek McDowell. Dr. Derek McDowell has a bio here, but I know him from medical school days. He's been my classmate in medical school. And Derek is somebody, Dr. McDowell, somebody of fame. He is a legend in his time, right? You'd have known of his pursuits on the football field with his Jamaica college team. And at times when he has had to create, I think it was a chest tube one time, he just had to innovate and create something to save somebody's life on the field. So, I mean, that is one of his creative and innovative ways that he's done things which saved lives, and Derek is always creating and innovating. And today, he's going to be speaking about an innovation called the wrist McTractor, your needed third assistant. I'm really curious to hear what this is about. But apart from what he's going to speak about today, he's an orthopedic surgeon and sports medicine physician. He's a multifaceted medical professional who has been a leader during the COVID-19 pandemic and the Haitian earthquake response in 2010. Notably, he has taken part in innovative and regenerative orthopedic surgeries. He earned his medical credentials at the University of the West Indies, Mona, and the University of Wales, Cardiff. Dr. McDowell is a co-author on several papers. So when he speaks, we can trust what he's saying. So I want us to give him your full attention and listen to what I know will be a very interesting presentation. So without further ado, let's welcome Dr. McDowell.
Good morning, everybody. Dr. Edwards Bradley, thank you for your very kind words. Thank you very much. And I'd like to thank the organizer of the conference for allowing me to present at this conference. The presentation will be on the arrest distractor, which we have named the MAC tractor, in your needed third assistant. I have disclosures to make. I was assisted by HART at the National Tool and Engineering Institute in developing and basically designing this instrument, and also Surgeons Jamaica Limited. This presentation will be a little deviation from our regular, method, results, abstract, that kind of thing, right? Because I'm presenting a surgical instrument which we developed and went through beta testing and so on. We've looked at a little bit of the historical perspective, look at the prototype, some of the indications for use, applications, some of the complications we have found, and some of the conclusions we have drawn. Now, in terms of the introduction, I personally got tired of being called as the third assistant in a lot of these surgeries to just pull on the bone, distract, meaning pull it apart, so we could get the fractures reduced, and then pass a wire across the whole and then apply a plate. And it's very, very difficult. You're pulling, you get tired. Sometimes you're not pulling the same direction as the surgeon. A lot of movement. And the surgeon will get a little bit upset sometimes. Say, hey, look, man, you're not pulling right. And so I got very annoyed sometimes, especially the junior person. You call in, you have to go, and you pull and pull and pull for an hour, and you get tired. So when my time came to be the surgeon, I developed a distractor. And there's a picture of it on the right of your screen. Let me just check. So it's on the left of the screen. Sorry. And it had a lot of parts, moving parts, and sometimes parts would get missing and wouldn't work as well. You say, hey, where's this part, where's that part? So we went ahead and developed the prototype, which had just 4 parts. You had the spanner, 2 pins, and the device you see beside the pins. When we assemble it, it's just a matter of putting 2 pins through 2 blocks, and you're able to distract with a bar and a nut. And of course, there's the bar on top. Right against the pin, it had measurements, so you know exactly how much to distract, how much you have distracted, so you could actually make an accurate assessment of what you're doing. Now, the indication for use of this device was in fractures of the distal radius, which is a bone at the wrist, fractures of the carpal bone, which are bones in the hand, and, combination of fractures and dislocation, meaning where the bones are broken and they're slipped out of position. And we have used some other interesting pathologies of the wrist, but it will be, I don't want to bore you with all that in this room. Let's keep it very simple. But I found it very useful for a number of conditions like this. Now, that's a picture showing the hand with the wrist, and it's labeled the ulnar the radius, and you can see that brown area, which is the fracture of the radius. Now, whenever that happens, it collapses. Almost like stepping on an apple, it just collapses. So the hand becomes deviated in a strange position, and to actually fix it, you have to actually pull that bone back out to length, and sometimes it's in many pieces. It's called community. You have many small pieces, and you have to put them together, and that can be a difficult task if you don't have the bone being held in place by a distractor. So what we do is at the base of the second finger, as you can see from the second one from the bottom, there's that large part we call the metaphysis. We'll put the pin in that area. And the other end would be beyond the fracture, more towards the elbow. And just where that gloved hand is, the other pin will be placed there. And on the right, you can see where the distractor is applied with just 3 moving parts, 2 pins and the distractor itself. That is just before surgery started. And that spanner now is used to turn the knob, and it distracts and pulls the bones apart. And if you have x-rays, you can actually see pulling apart and you know where you are. Now, hope nobody gets upset with these pictures, but that's surgery. And you can, if you don't have an x-ray, intraoperative x-ray, you can actually look and see the bone pieces coming together. Now, on the right-hand side, that's the x-ray of what's going on here. And there's a fracture, believe it, of the bone just to the bottom of the screen. And we're able to pull the fragments apart, hold it there, and you're free to operate. You can turn your back, you can talk, you can ask for things. The assistant is not complaining and saying, "Boy, I'm tired, hold on a little bit," it's slipping out of my hand. And there we put a screw across the offending fracture, reduce the bone, but there's more. We now need to pass wires across to hold the bones in place. So there are two wires which are forming a V with a point in them. You hold the bone in place. The other wire across the joint is holding that joint in place. And it's all done quite simply, 10-15 minutes, and the assistant is not complaining, "I'm getting tired." Another use of it here, I should say that's the hand after we fix everything, looking normal. We've taken it off, and the dressing the patient goes home or goes back to the ward. This is a case where the fracture across the wrist, if you look just below the hand, you see a lot of bone fragments. You could hardly make it out. Apply the distractor, and it pulls it all the way out to length. And at surgery, we simply snap the bone portions back in place, put a plate and screw on, and that's it. And that's it. That's the end product. It takes about 5 minutes to apply a distractor. Surgery takes about 10-15 minutes, and you're out of there within 25 minutes, as compared with 2 to 3 hours with the old method. Now, some of the complications we have found, pin placement. The pin that's placed close to the elbow, if it's placed so close to the fracture site, it gets into your surgical field and affects you applying the plate. Because sometimes you have to use a lot of force because fractures are old, sometimes the pins bend. And we have had bones that are fractured with improper placement of the screw, the pin that's placed in the hand. In conclusion, the Mac tractor works. And really, the name Mac tractor is really distractor and McDowell. So we call it a Mac tractor. And it's a registered name. It's easy to apply, and it's applied with anatomical landmarks. You feel them with your hand. You don't need an X-ray machine to do it. And it does not need an image intensification, I mean a C-arm while you're operating. In conclusion, the distractor never complains, never gets fatigued, it never complains. There's a decrease in surgery time, and I mean decrease significantly by about 2/3 to 3/4. So it goes from like 2 to 3 hours down to about, let's say, 45 minutes on average, but it can be 30 minutes. There's no need for an additional surgical assistant. I minimize the instrumentation needed in the sets at surgery. In conclusion, the wrist-Mac tractor is a necessary tool in your surgical armamentarium, and I never start surgery without applying it, never. Some of my colleagues think I overuse it, but I don't. I never start surgery without it. It makes surgery that simpler and that much easier. I just want to say at this point in time, thanks to Dale Thompson, who is an employee of the National Tool and Engineering Institute. He's a training-based enterprise manager. He's a trained mechanical engineer and a certified welder, and he was actually instrumental in getting this implant built properly. His attention to detail and precision is just amazing, and we had many meetings with him, and he said this is what it needs to look like, what it has to look like, and he was just amazing in terms of the advice he gave. Mr. Winfield Boban, CEO of Surgic, he gave his honest critique when we were getting tired of, Dale and how Dale's attention to detail. And so he said, look, man, just work with it. And the tenacity was just amazing as well. At this point in time, I also want to say we have applied for a product patent on this. The idea is not unique, but certainly the design patent is where we can get the design here. So it's in, that's why I'm able to talk about it now. And thank you to Mr. Boban, Dale, and our orthopedic nurse again, whose critique and analysis and just her attention to detail as well and ease of use was critical. Thank you all very much for listening.
I told you it would have been exciting. Oh boy, make you feel like a Jamaica, boom. I know it's a Caribbean effort though. The encouragement came from the Caribbean. So it's amazing, I think, if we put our minds together to do something, I mean, we'll be able to do amazing stuff. Can you imagine reducing a surgery from 2 to 3 hours to 45 minutes just by creativity and innovation? Amazing. Amazing. It's better for the patient, better for the doctor, better for everybody. All right, so now we're into our question and answer session. And I've been asking you to write down your questions to ask at this stage. And if there's anybody with any questions in the room, I don't know if there's anybody monitoring the online situation to see if there are any questions there. Yes? Dr. Grant? Oh, you have the microphone? Go ahead.
Good morning, everyone. And I probably need to stand for this because I am indeed happy that I'm at this research, or 14th research this year. I am elated. I'm feeling good because indeed I've seen 3 excellent presentations this morning. And as we seek to close the gap with our, sustainable goals and moving towards universal health coverage, this is the way forward, right? I can see from all 3 presentations, words coming out: efficiency, access, quality. And I am indeed, I want to just commend the 3 presenters here this morning for excellent presentations. And just to say that I hope and trust this is really some best practices going forward, and I hope and trust that you'll be able to share them across, I know you have started to share already, but I'm hoping that it will just, take on wind, and in the rest of the regions and the rest of the health departments, especially for Cameron Bennett. I really like that initiative, and I see how best you could really take a pick from and use some of those qualities to build out those different areas across environmental health. So thank you so much, and you have enriched my life today with the presentation so far. Thank you.
Yes, good morning, everyone. I just want to commend the excellent presentations, and it is quite interesting to know that innovation is happening in Jamaica. So I just want to really commend the presenters. I want to start, I have 2 questions really. One is for Dr. Matt Dowell and one for Dr. Barwise. So for Dr. Matt Dowell, very excellent and interesting presentation. Thank you very much. I was going to ask about the next steps, but you did mention the registration with JIPO. The one question I have, because since we are in a research conference, I was wondering if the next step, or you want to see who is speaking? Yes. So I'm wondering if the next step in terms of documentation, are you planning to do any kind of trial, any kind of documentation? So yes, you have the evidence to say that the surgery has moved from 3 hours to, 45 minutes. Is there documentation in place in terms of a trial, etc.?
Thank you for your question. Okay, presently we are doing the beta. Well, we have actually done the beta trial of the instrumentation before the prototype. We're now doing the beta trial of the prototype and documenting surgical time, meaning time to apply and time of surgery, and also trying to categorize the surgeries in terms of how it can be used and the timing of the various types of surgeries, and of course the historical reduction in time from the older methods.
Okay,
we're also into production and marketing as well.
Thank you very much for that.
Okay.
And the second question, thank you, Dr. McDowell. The second question was for Dr. Barwise. And I thank you again for a very interesting presentation. The question that I had when you were presenting is, we are operating under an ideal when we don't have an outbreak or an emergency. But when we are in an emergency situation and we need data very quickly, then we see that databases, etc., are developed that don't necessarily speak to each other. So I'm wondering, because you had mentioned the assessment of certain databases, the ComCare, etc. I'm wondering what is the ideal with respect to that, because we come across the same challenges again and again where we develop databases quickly, but in the long run it is costly to us because they don't speak to each other.
So what we've tried to do with my health platform and the technologies that we're using is that the data that would be available in My Health is accessible real time. So if there was an update to the ComCare database, it would show up in My Health literally within a few minutes. We've also taken into consideration, of course, the fact that the Data Protection Act is coming in, and considerations about accessing patient information. And again, one of the things that we've championing, particularly like I mentioned with identity management, is ensuring that the right person has access to the right records. So we've also made records federated based on the location that the patient is at, but there's also an audit trail so that if you accessed a patient record from a hospital maybe that you're not assigned to currently, there definitely is an audit trail of that. There's actually a warning, but we also have to take into consideration that our patients traverse various facilities, so there will be the need to access a patient's record, that a patient that was at KPH from UE or a patient that was in the Western region, because our patients are going to traverse the whole island. But still taking into consideration those data protection and access considerations. But the way that this platform has been created, the data is supposed to be available real time. And it's supposed to be an inclusive database of all the systems. And we eventually want to add all the current electronic systems so for you to be able to access them in a single interface. So you're not having to log into separate systems or try to access separate systems to be able to gain access to the data.
Okay, don't go Dr. Wise. I have a question for you. Let me just congratulate the team on, stand up. I was told to stand up. Okay, let me congratulate the team on awesome presentations. I have a few questions. Dr. Wise, I would appreciate if you could share the data wheel via Mr. Martin. I want to see how well it fits into our sexual and reproductive health scope of data collection and analysis. My question for you is with regard to, if it is that a patient call himself John from Montego Bay and he comes to Kingston and he is Jenny, how will the data recognize, how will the system recognize that it's him? Because the system is going to be now connected, but at first point of health care, he is John. Because we have to recognize that we are in a space of transgender and so on, and persons do move around. So he's John in Mobay, but he comes to Kingston and he fell ill and he presents himself in a dress as Jenny. Don't answer yet, I'm going to the other. Dr. McDowell, hearty congratulations. I have just a few questions for you. Would your method be applicable to a pediatric patient? Just 3 questions. And how long does the current method, how long, if when you do the surgery on a patient, does that patient recover? Does it take for the patient's wrist to get into full range of motion after the surgery? And finally, for you, Dr. McDowell, could the same thing be done on the ankle? So that's it for you. And for Mr. Kumar, are there plans to take this case study throughout the entire island, given how valuable it is at this time? Over.
Thank you for your question. So, us starting to do electronic systems does not negate a lot of the valuable health records practices that currently exist for us to help to identify patients. What it is doing is facilitating that. So of course like you said, things are going to become more centralized. So we'd have this centralized register of patients, but it would still take interrogation, some level of interrogation of the patient from the perspective of, okay, I'm looking in the system, I'm not seeing you, and starting to try to elucidate some other points. We're also assigning each patient that we would register with the system a unique identifier, and I think there's still discussion about whether or not they'd be issued a physical card or not, if that is how it would be approached. But if the patient has that number, then that would allow us to access the records at other places. Of course, as you mentioned, we are aware that we have members of our population that are transgender, and I know that it's a very controversial topic, but in our modeling, we did make accounting for that when we were doing the demographic standardization. But of course, we need to also approach that from a legislative perspective, because currently the current legislation doesn't recognize that. In addition to that, we also have been exploring if we're going to tie the digital health number to a national identifier that will allow us to reliably identify someone. So again, if they presented one of the national IDs, that is another thing that would help us to be able to identify that patient, that we have the capacity to capture all of those as well. We also want to do some validation against those national identity databases. So those are some of the ways. It won't be a perfect system. And over time, it's something that will become more and more refined. We also are using algorithms to help to differentiate between patients who might have very similar names and similar demographic details. So it's a multifaceted approach to it. There might be the instance where 2 different records are created, but if the patient is able to tell us that, and we're able to reliably, again, going through the steps to identify his patient, then we can link those 2 records. I hope that answers your question.
Just looking forward to the way in which you can deduplicate.
Oh, so the algorithms within the master patient index help with that. So that's definitely something that the system aims to address. I forgot to mention in my presentation, because I was a little nervous, that I just got back from the SNOMED CT conference that is held yearly in Atlanta. And our work was, we shared the work that we've been doing, and it was very well received. We actually had colleagues from Norway and Canada and Sweden who were really impressed that we're moving from paper to best in breed. And Jamaica is leading. We recently became the first member in the region to join SNOMED CT. So, as always, we're doing good work. Thank you so much.
Okay, thank you for your questions. The first question, I think, was, let me answer the pediatric question first. The kind of fracture patterns in pediatric patients don't usually require distraction. Okay, so I've never used in the pediatric population before, but I'm sure if one day comes up, we'll just have to alter the size of the pins and the location of the pins, okay? But the pediatric population, the fracture patterns do not usually require distraction. Okay, this distractor basically assists us at surgery to get the bones in the right position, and the bone now heals as per usual within 4 to 6 weeks, and then it's 4 to 6 weeks of rehab, and the patient gets back function, get back to maximum medical improvement. And the other question answers about the ankle. Okay, so you push me now. This was called the wrist, WRST, wrist MAC tractor. We have 2 other distractors. We have an ankle distractor, an ankle MAC tractor, and a shoulder MAC tractor. But these are used for arthroscopic surgeries, not for treatment of fractures. So we distract the ankle joint so we can actually see into it when we're doing minimal access surgery, and same for the shoulder. So, but it's not used to treat fractures of the ankle. Okay, thanks.
Thank you, Dr. McDowell.
Welcome.
All right, so the question was about scalability, if it's applicable, the system is applicable island-wide. All right, it was developed with that in mind. We had arrived at a method, a little system that we can use to denote the parish. So each establishment, other than the fact that GPS coordinates are unique to that establishment, an ID is generated, and if you knew how the system worked, I mean, in the manuals and so on, it would describe how it works. There's a number that's generated, an ID number. Upon looking on the ID number, you can clearly denote the parish, the zone or health district within the parish that establishment is found, the category of establishment, whether it's a full-service restaurant, quick service restaurant, processing plant, or something. So that little bit of, that small snippet of information gives you so much about the establishment. So a transition to spreading across the other regions and island-wide would not necessarily be too challenging. All we need to do is just continue adding establishments. Once it's in a specific parish, the system would automatically know that that's the parish that it's in. I mean, no, the word no probably suggests sentience, but the system would be able to pick up that it's in whether Western region, Southern region, Southeast, etc. And it would apply that information accordingly. So all the establishments in Jamaica, all food establishments in Jamaica, in theory, could be stored in that one database. And what we also did for a sort of redundancy is to ensure that this database would be mirrored across all the regions where it would be used. So each region would have a copy of this database that mirrors itself for redundancy. So in case KSA's system would go down, in case KSA's system would go down, we would be able to get backups from other remote locations. So a number of redundancies and contingencies were built into the system. That was it, right?
All right, we have time to take 2 more questions. You're on the floor. Okay.
Good morning. My question is for Dr. Barwise. Will researchers be able to access data from My Health? It's a 3-part question. If yes, is there currently a protocol for patients to sign over, just to give us permission to access their data in order for us to do analysis? Is there currently? And what's the protocol for us to access variables from the My Health database?
So there definitely is a plan for researchers to be able to access the data. It would still need to go through the ethics processes that currently exist. Normally, the patients actually as a part of My Health have the ability to grant and revoke access. And so we do take into consideration patient authorization of access to their data. So as we develop that aspect of the system, we would probably allow patients to opt in or out whether or not they want to be included in research or not. But that's probably something that we need to explore a little more.
Yes, that would be very nice. Thank you.
Hi, good morning, everyone. This question is from Hector Burrows from the EPI unit. It's for Mr. Bennett. Excellent presentation, Mr. Bennett. I'm really proud of the work that you and your team have been doing. But the questions are, what is your relationship with eGov Jamaica? And do you plan to be a part of their network, or will your servers remain housed at the health department or the health region?
That's a question from Mr. Burrows, right?
Yes.
All right, tell him thanks for the question. All right. The thing about this system is, due to the restrictions in the Data Protection Act that's supposed to come in force a couple of weeks from now, all our data that's related to what we are doing within the parish must be housed locally, essentially within Southeast Regional Health Authority. We have not yet approached eGov or any such entity as yet, because we are pretty much in our early stages, in the infancy stages. And we are still doing our field tests in Kingston and St. Andrew Health Department. We haven't encountered anything that would suggest that it is not. I mean, as much as it is being developed by our unit, and I don't want to be the person who has nothing bad to say, but really we haven't heard any significant issues come up as yet that would prevent full rollout. So whatever the regulations that govern what we are doing would dictate, I'm pretty sure we would definitely have to work with whatever restrictions there may be. So as far as eGov is concerned, we haven't really made any contacts to them to determine what the requirements would be. That's it.
Okay, thanks.
All right.
All right. I think you all agree that this was a great session, so I just want to give the speakers a hand. And as chair of this session, I'm just going to use the opportunity to just plant a seed. We have the brains of the Ministry of Health here. We have a GIS system set up at the KSA, and one of the things I've always thought of that we can use it for is, well, when we have our electronic health records, we can now use GPS systems to locate people's houses, right? One of the problems in Jamaica is people come from districts and you can't find them. So we can go on a map, trace them and say, is this your house? Yes. And we put in the GPS, the GPS location. We can now determine, with all these different people with different surnames coming from the same house, which is a Jamaican reality, just by entering their address, we'll now be able to say, okay, this person is related to this person in some way, whether they are relatives or not, but they're coming from the same location. And I think that if we probably can work towards that, I think we can have more control over disease control. We can have better understanding of what diseases are coming from which household even, not even just the community or the district, but even from the household. So I'm just going to leave that with the team, planting a seed, that's all I'm saying, and thank you all for listening. All right? Thank you very much.
So before our presenters go, we want to express our appreciation one more time for the excellent presentations. And I also want to point out that this is a special feature for this year's conference. When we read the abstracts, the research abstracts, it was felt by the adjudicators that these were special presentations that needed to be pulled out and highlighted, hence this presentation on applications of technology in public health. And so we want to give some small tokens of appreciation, firstly to our speakers. So we'll start with Mr. Cameron Bennett. And then we are going to go to Dr. Keisha Barwise. And then we go to Dr. Derek McDowell. And we also want to give a word of appreciation to our moderator, Dr. Bradley Edwards, and we want to thank him for taking us through this session.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations, and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
Good morning, ladies and gentlemen. Oh. It's time for us to go into session number 3, and I hope that we have been enjoying the sessions so far. I see a few people responding. If you really have been enjoying the sessions, let me hear you say hallelujah. All right. Beautiful indeed. So I will be introducing our presenters for session number 3. And it has been exciting, the research that has been done, the body of work that has been put together by these, I want to call them illustrious researchers. This morning, we have 4 researchers who will be presenting to us. We have Miss Annetta Gordon. Miss Annetta Gordon holds a Bachelor of Science and Master of Philosophy degree in biochemistry and is currently pursuing a PhD in biochemistry. She serves as a teaching assistant in the Department of Basic Medical Sciences at the University of the West Indies, where she assists the undergraduate students in the mastery of laboratory protocols and analytical techniques. Her research entails the studying of natural products and identifying their phytochemicals and mechanisms of action to assist in the treatment of diabetes and hypertension. She has a motto in life: if it is to be, it is up to me. And she enjoys volunteering and being involved in students' personal and academic development. Miss Annetta Gordon will be presenting on the effects of semi-purified fractions from Plectranthus blumei, affectionately called Joseph coat, in normal, healthy Sprague-Dawley rats. Our second presenter is Mr. Amarley Wright. He earned his BSc degree in biochemistry with honors and recently obtained his MSc degree in biomedical research with distinction from the Faculty of Medical Sciences. And that is at the Department of Basic Medical Sciences at the University of the West Indies. One such disease that sparks his interest is diabetes mellitus, which directed his research into experimental studies to improve glycemic control in type 2 diabetic animals. This has promoted his desire to bring about transformational changes in public health through evidence-based research, and he is a Monroe old boy. He will be presenting on combined supplementation of S-nitrosoglutathione and glutathione for diabetes treatment. I am bubbling over with anticipation. Please make them feel welcome. Okay, so we go to our first presenter, Miss Annetta Gordon. Thank you.
Good morning, everyone. My name is Annetta Gordon, and today I will be presenting on the effects of semi-purified fractions from Plectranthus blumei, commonly known as Joseph coat, in normal, healthy Sprague-Dawley rats. Folklore medicine is the knowledge acquired through generations of practicing indigenous medicine. Many plants have been utilized in the treatment of illnesses such as diabetes mellitus. One such plant is the cinnamon plant. Other plants have also been explored and shown to have medicinal properties, such as members of the Plectranthus genus, for example, Plectranthus amboinicus. Joseph coat originated in Central and South America, and it's grown across Jamaica as an ornamental plant. It grows 1 to 2 meters in height with broadly ovate, rounded leaves. It is locally used in the healing of wounds and the treatment of diabetes. It is also used as an antimicrobial agent, an antihelminthic, antispasmodic, and as an expectorant. So the separation techniques that was utilized in this research is thin layer chromatography and column chromatography. Diabetes mellitus is characterized by hyperglycemia, which is as a result of defects in insulin secretion, action, or a combination of these two. It can affect organs such as the kidneys, and some symptoms include polyuria and polydipsia. There are different types of diabetes, such as type 1, which is due to cellular-mediated autoimmune destruction of the pancreatic beta cells, and it's responsible for 5 to 10% of diabetic cases. Type 2 diabetes is defined by insulin resistance and relative insulin deficiency, and is responsible for 90 to 95% of diabetic cases. In diagnosing diabetes, there are different tests, such as the glycated hemoglobin test, fasting plasma glucose, random plasma glucose test, and the oral glucose tolerance test, which tells how well the body is able to metabolize glucose, and this is a test that was utilized in this research. So in diagnosing diabetes using OGTT, a person is considered normal or having a normal reading when they have a value of 7.8 millimolar per liter or less. For a person who is diabetic, they will have a reading of 11.1 millimole per liter and greater. So in Jamaica, diabetes is one of the top 5 causes of death, with 11.6% of the adult population being affected. It is expected that by the year 2045, in the North America and Caribbean regions, cases will rise to 63 million from the current figure of approximately 48 million. As a result of this expected increase, more research needs to be done to identify treatments with less side effects, and more effectiveness. So the aim is to investigate the effects of Joseph coat semi-purified fractions on blood glucose concentration in normal healthy Sprague-Dawley rats. The objectives are to obtain various crude extracts and bioassay these crude extracts on blood glucose concentration using OGTT, and to purify the active hypoglycemic crude extract using chromatographic techniques, and to identify the naturally occurring hypoglycemic compounds using spectroscopic techniques. So the plant was collected from Georges Valley, Manchester, identified and assigned a voucher specimen number by Mr. Patrick Lewis at the UWI Herbarium in the Department of Life Sciences. So the plant material was dried and milled and treated with hexane for 2 8-hour period, and then overnight, and the crude extract obtained and then bioassayed. The plant residue was then treated similarly with ethyl acetate and methanol, and the crude extracts obtained and bioassayed using the OGTT method. So for OGTT analysis, this was done using a modified method by Islam and Wilson in 2012, and the rats were collected from the UWI animal house, fasted overnight for approximately 12 hours, and given water only ad libitum, after which the fasting blood glucose sample was taken and monitored using the AcuCheck glucometer. The crude extracts were then administered intravenously at 50 milligram per kilogram body weight, while the semi-purified ethyl acetate subfractions were administered intravenously at 30 and 20 milligram per kilogram body weight. Blood glucose level was then monitored at the 30-minute and 60-minute intervals after administration of the extract or the control. Following the 60-minute reading, a glucose load was administered orally, and the blood glucose levels were then monitored at the 30-minute intervals for a further 2.5 hours, and a graph of blood glucose concentration versus time was then plotted. For purification of the ethyl acetate crude extract, this was done utilizing column chromatography with a solvent system of acetone to hexane. For the purification of the subfraction F, this was done utilizing column chromatography with a solvent system of dichloromethane to ethyl acetate. Ethical approval was sought and granted from the UWI MONA Ethics Committee in 2018. For statistical analysis, the data throughout the experiments were collected in duplicate and average and analyzed using SPSS version 20 independent sample t-test, and values were considered significant at p less than or equal to 0.05, and graphs were plotted using Microsoft Excel. Now on to our results. So here is a graph showing the crude extracts administered intravenously at 50 milligram per kilogram body weight, and we have blood glucose concentration versus time. In black, that is the control, and what we realize is that after the glucose load was administered at the 60 minutes, there's a general increase in the blood glucose concentration, followed by a general decrease, which is due to the action of insulin. When we look at the methanol crude extract in red, we see a decrease, and also, which is of great importance, in yellow, there is the ethyl acetate crude extract, and this should lower the blood glucose concentration when compared to the control, which is DMSO in black, significantly, and so we decided to purify this crude extract. Upon purification of this crude extract, we obtained 10 subfractions labeled A to J. We then bioassay these fractions. So for fractions A to C, we saw that fraction A and B showed a decrease in the blood glucose concentration when compared to the control, and this was evident in the fasting period, which is the period from 0 to 60 minutes, and the postprandial period, which is the period after 60 minutes. For fractions D to F, we should notice that F showed significant activity when compared to the control. For fractions G to J, we notice H showed significant lowering when compared to the control, which is in the black, which is DMSO. So here's a TLC showing the profile of the fractions that were obtained, and we realized the fraction A, B, and F, they showed activity, and there's an overlap in the TLC, which could give an account for why we are seeing the activities. So here's a comparison of the subtractions when administered intravenously, and what we realized was that for fraction F, it was able to lower the blood glucose concentration significantly, so we then decided to further purify the subfractions, and we obtained 6 subfractions. Upon administration of these fractions, we realized F2 showed lowering, and F5 as well. So here's a comparison of the subfraction of the mother fraction and subfractions, and we realize that as the fractions become more pure, we saw an increase in the activity. So with fraction F5, we elucidated the structure using GC-MAT spectrometry, and we identified 3 compounds: palmitic acid, stearic acid, and arachidonic acid. So in conclusion, the natural occurring compounds that are present from Joseph code producing the hypoglycemic effects are palmitic acid, stearic acid, and arachidonic acid, which are fatty acids in nature. Thank you.
Good morning, everyone. So I am Amarli Wright, and I want to thank the National Health Research Conference Secretariat for inviting me today to present. So today I'll be presenting on how combined supplementation of S-nitrosoglutathione and glutathione improves glycemic control in type 2 diabetic rats. Now, diabetes mellitus refers to a group of metabolic diseases, and it is primarily characterized by high blood glucose concentration, also called hyperglycemia, and this can be due to defects in either the secretion of insulin, the action of insulin, or both. It is categorized into 4 categories. We have type 1, type 2 diabetes, gestational diabetes, and specific types of diabetes due to other causes. However, type 2 diabetes accounts for a majority of diabetes cases, which is approximately 90 to 95%. Now, diabetes mellitus is a chronic condition, and it still remains a global health issue today. If we look at some statistics, we can see that the prevalence of diabetes worldwide in 2021 was 537 million, and it is projected to rise to 643 million by 2030. If we zoom in on Jamaica, in 2021, the prevalence of diabetes was 11.6%, which accounted for 231,100 cases. And by 2030, it is expected to rise to 273,100 cases. So we're seeing that diabetes is not only a huge problem, but it's a growing one. So for my study, glutathione is one of the compounds involved, and it is a tripeptide made from 3 amino acids, cysteine, glutamate, and glycine. It is a major antioxidant that's produced specifically in the liver, and it exists in 2 states in the body. We have the oxidized state and the reduced state. A study has shown that there has been decreased levels of glutathione in diabetic patients due to a deficiency in cysteine and glycine. S-nitrosoglutathione is the other compound involved in this study, and it is due to the reaction of glutathione with nitric oxide. It is referred to as a S-nitrosothiol, and it is used in experiments because it has the ability to yield nitric oxide. Nitric oxide is a very important compound and a very interesting one. It was originally thought to be just an environmental pollutant, but they discovered that it was produced in the body. It has been identified as a factor in the development of diabetes. So both S-nitrosoglutathione, GSNO for short, and glutathione are found naturally in the human body, and glutathione plays an essential role in reducing oxidative stress due to the generation of free radicals in conditions such as cancer and diabetes. In a study by Bryan in 2014, she reported a significant lowering of blood glucose concentration when S-nitrosoglutathione and glutathione were administered separately, as well as glutathione was administered by itself in normal rats. For this study, the aim was to investigate the efficacy of GSNO and glutathione combined supplementation as a potential treatment option for type 2 diabetes using streptozotocin-induced type 2 diabetic rats. Given that diabetes has a high prevalence as well as high mortality rate, and the global health expenditure in the North American and Caribbean region was approximately $966 billion in 2021, we see that that is going to increase, and therefore we need effective treatment methods. The study that was conducted by Bryan in 2014 showed promising results as it relates to the significant lowering of blood glucose levels in normal rats, so we sought to evaluate this treatment in diabetic rats. I'll go into my methodology, but first I must say that we obtained ethical approval from the Mona Research Ethics Committee. So this is my experimental study design that was adapted from Wilson Islam 2012. So from weeks 1 to 4, we conducted diabetic induction. So this involved feeding rats a normal rat pellet diet as well as 10% fructose solution. In week 3, we injected them with streptozotocin at a dosage of 40 milligrams per kilogram body weight. Afterward, we tested non-fasting blood glucose concentration, where a reading that was greater than or equal to 16.6 millimoles per liter was considered diabetic. From weeks 5 to 8, we had treatment, and the rats were divided into 5 treatment groups: the normal control, the diabetic control, the GSNO only, the glutathione only, and the combination group, with the respective dosage as seen. The 6 rats were separated into each group, and they were fed the compounds orally for 28 days. For measurements, we took the weekly non-fasting blood glucose concentration. We also measured daily food and fluid intake and plasma insulin concentration. For statistical analysis, we use SPSS version 25, and a NOVA test as well as Tukey post-hoc test was used for statistical analysis, where a p-value less than 0.05 was considered statistically significant. Let's look at the results. So for the non-fasting blood glucose concentration for the normal and diabetic rats, first I'll remind you that from weeks 1 to 4 was diabetic induction, and then from weeks 5 to 8 was treatment. Now if we looked at the diabetic control as well as the GSNO group, which are showed in red and purple at the top, we saw that there was a significant increase in non-fasting blood glucose concentration from weeks 4 to week 8. When we look at the glutathione only, which was in green, there was a significant lowering in blood glucose concentration for treatment for weeks 5 to 8. And then when we look at the combination group in blue, there was an even more pronounced lowering in blood glucose concentration. There was no change for the normal. When we took a look at plasma insulin concentration for both the normal and diabetic rats, for the glutathione group as well as the combination group, seen at the both bars at the end, we saw that there was a significant increase in plasma insulin concentration compared to the diabetic control, and this was comparable to the normal seen in yellow. Now we look at food intake for the normal and diabetic rats. I must indicate that the various letters that you see above the graph, where you have different letters, it indicates statistical significance. So from weeks 1 to 3, we did not see a significant difference in the food intake for any of the treatment groups. However, from week 4 to week 8, we saw that there was a significant increase in the food intake for the diabetic groups. When we look closely at the combination group, there was a reduction in food intake from weeks 5 to week 8. So as treatment went along, there was a reduction in the food intake for the combination group. Similarly, for fluid intake, there was no change in the fluid consumed from weeks 1 to 3. However, after induction in week 4, we saw that the diabetic groups had an increase in fluid intake, with the diabetic control having the greatest increase. For the combination group in blue, we also saw that there was a steady decrease in fluid intake over treatment. Now, from these results, we saw that diabetic rats in this study displayed common symptoms of type 2 diabetes: increased hunger, increased thirst, frequent urination, and high blood glucose levels. We saw that the combination treatment significantly reduced the non-fasting blood glucose concentration, as well as food and fluid consumption in diabetic rats when we compared them to the control. That's the diabetic control. There was a notable increase in plasma insulin concentration that was observed for the combined group, for the combination group, as well as the group that was administered glutathione only. So we saw that the combination group therefore improved glucose metabolism, increased satiety, and decreased thirst in diabetic rats, and this was possibly through some mechanism which affects insulin secretion. For a conclusion, we're saying that antioxidants such as glutathione have the potential to serve as a therapeutic option in treating diabetic patients. There are currently clinical trials that are underway now with glutathione. I've highlighted one which is occurring in India, where they reported oral supplementation of 500 milligrams of glutathione daily to diabetic patients for 6 months, and there was a decrease in the blood glucose reading after 3 months. That's the HbA1c level. From this study, just to reiterate, we see that the combination therapy may prove beneficial as a pharmaceutical treatment for management of type 2 diabetes. However, additional research is needed to determine what mechanism is occurring that results in this improvement in glycemic control. We also need further exploration of preclinical studies as well as clinical studies to evaluate how we can improve the quality of life for many diabetic patients, and more specifically for Jamaica to reduce our health expenditure. These are my references, and I thank you for listening.
Thank you very much, Mr. Amali Wright and Miss Annetta Gordon. This indeed was food for thought. When I look at the 2 bouquet of flowers, I said, are they real? Because they're not only, if they're real, they not only beautify our environment, and remember, they make us smell good, perfume, and now we get medicine from flowers. What a great God we serve. At this time, we shall go into our question and answer section, and I'll go to the online questions first. Oh, nobody's online? All right. Do we have any questions from the audience? Any questions? Yes. Okay, you can go ahead.
Thank you so much. Is it Mr. Wright? And Ms. Gordon. Excellent presentations from both of you. But I do have a question for Lady Gordon. You see, I'm from Manchester, and I want to know, I recognize that you took those plants from Georges Valley in Manchester. Any particular reason for that?
Okay, so well, one of the things, with doing this research is that the plant Joseph coat is not readily available like first time. So I was looking around, and then when I went, I have family from Georges Valley, and I was asking around for the Joseph coat plant, and I found it there. So with research to ensure that there's no error, like for example, you have to like not necessarily read, but take the plants or from wherever it is to extract the plant. You have to extract it at a particular time period, so that can not introduce like new compounds to ensure that you're working with the same plant. So I had to ensure that it's at that area, I will always get it. Yeah.
Access and availability.
Yeah, access and availability.
Mm-hmm. All right, thank you so much. Another question. Now that you recognize that based on your findings, it looks good and you see that there's some positive light there, what's the next step?
Okay, so for my PhD, I am planning to induce diabetes and then see the mode of action of these compounds to see how exactly it helps with diabetes.
Okay, thank you.
Okay, thank you.
Thank you very much. We'll take just one more question. All right. Thank you very much. Can we give them a hand again? Thank you. All right, so we move into the other two presentations. We have Mrs. Annalie Gray-Brown, nutritionist, currently working as a research assistant at the Caribbean Institute of Health Research. She's involved in research and advocacy activities in support of healthy food policy initiatives underway in Jamaica. She holds a MSc in nutrition and a BSc in dietetics and nutrition with professional certification in the areas of online training and nutrition therapies. Annalie believes that everyone should have access to the resources needed to maximize their full potential. This drives her interest in supporting the Sustainable Development Goals on good health and well-being and protected quality of life for all. Our second presenter, can you give her make her feel welcome? Thank you. Ms. Laura Gay Findlay holds a BSc in dietetics and nutrition from the University of Technology, Jamaica. Currently, she works at the Caribbean Institute of Health Research as a project assistant on the Jambar Kids School Environment Study. Here, she is involved in both research and public engagement activities supporting healthy food policies for schools with a focus on assessing food and beverage marketing. In addition to building on her experiences in nutrition education and food service management, Laura's professional goals include securing children's right to healthy nutrition. Can we make her feel welcome? So at this time, we will proceed into the presentation, and we'll have questions and answers after we are through. So Mrs. Annalie Gray-Brown, thank you.
Good morning, and thank you again to the Ministry of Health for allowing us to share on our work. So as you can see, the topic is fruit and vegetable intake in Jamaican school-aged children. So, as we know, we need fruits and vegetables in our diet. They provide essential nutrients for children's growth and development. We have substantial evidence that points to low consumption being linked to poor health, non-communicable diseases, micronutrient deficiencies. And globally, we have inadequate intake, both in children and adults, across many populations and life stages. So generally, food preferences are shaped from in childhood as well as eating behaviors. And the challenge is that competitive foods like sugary beverages, salty snacks, candy can actually replace or displace fruits and vegetables in the diet. Children spend a lot of time in school, as much of a third of their weekday, and so schools provide consistent exposure and access to foods. And so because of this, really, fruits and vegetables should form a part of school meal programs. So while we know the intake globally is inadequate, we are actually not sure about the intake in Jamaican school children, and so that's what we set out to find out. So our objectives were to describe the weekday fruit and vegetable intakes in Jamaican primary school children, the type and amount, meal occasion, for example, breakfast, is it a snack, and the source, that is where they're getting it from. We are also looking to determine the adequacy of intakes using the World Health Organization's 2023 recommendations for fruit and vegetables. So the study is really a subset of a larger study, the Jambar Kids study, and it included 30 primary schools, 26 public, 4 private or independent in Kingston and St. Andrew in 2019. We had 729 children, roughly the same amount of boys and girls, ages 7 to 11 years. You're seeing an extract of the 24-hour recall. It's a single recall that was modified to capture the weekday intake of fruits and vegetables. We did collect beverage data, but today we're only focusing on the fruit and vegetables. We used trained nutrition personnel and food models as well to aid the accuracy of the recall. To analyze the data, we had to prepare it. So we got the descriptions of the items and we converted those intakes to gram estimates using data from food composition databases and research publications. Then we tallied all of this data and compared it to the WHO fruit and vegetable recommendations. And these recommendations are age specific. So if the child was 69 years, then it's 350 grams for the day. If they're 10 years or older, then in total 400 grams for the day. And we analyzed the data. We are presenting them as frequencies and means, and we checked for differences. We looked at sex, we looked at weight status as well, age and so on, but we really only found differences when looking at source, and in particular, school versus other as a source. So, note our results. 36% of our children reported consuming fruit. 50%, basically half of them, reported consuming vegetables. However, it's difficult to show this data easily, and so we thought a word cloud would be a good way to showcase it. So the larger words indicate the most frequently occurring or reported fruits and vegetables, and we're seeing that bananas, otaiti, apples, and oranges were the most frequently occurring fruits, and cabbage, lettuce, and mixed vegetables were the most frequently occurring vegetables. Now, when are our children having the fruit and vegetables? So the green is the vegetable, and we're seeing the longer bars for lunch and dinner, so that's when they're having it most often, or when most of them reported having vegetables. For fruits, it's in yellow, and they're primarily having fruits at breakfast, at the AM snack, and some at dinner. It means, therefore, that not much fruit was being had at lunch or the afternoon snack. So who or where are we getting the fruits and vegetables from? So the way the table is set up, it's on the outside you have the percentage, and in brackets we have the frequencies or the counts. And we're seeing that schools provided roughly 17% of the total fruit intake for the children. 19% came from the street vendor at the school, and 66% came from home. So children are reporting getting home more than 3 times as fruits, more than 3 times as much from home than from school. For vegetables, 52% actually came from school, and 61% came from home. And we're seeing that for school, it's primarily from the canteen or the PATH program. And how much are they actually having? So the first column is just describing fruits, then vegetables, and then the combination, the tally of fruits and vegetables. The second column is the general population, and the remaining columns are for those who are consuming. And what we're seeing really is children are consuming inadequate amounts in total, because in an earlier slide we mentioned that 350 grams to 400 grams is the daily target, but children are having much less than that. We're also seeing that a lot of it is actually coming from school, so it's bolded right there, and we're seeing that the only significant difference is that children are getting much more fruit and vegetable from school than from any other source. Earlier I had said as well that 36% of children were having fruit, 50% were having vegetables. When we looked at the total data, only 9% were actually meeting their daily target established by the WHO. So in summary, children are having a variety of fruits and vegetables. They're having larger servings or larger amounts of fruits. They're primarily having fruits at breakfast or snack times, and they're having fruits 3 times more often at home than from school. They're having vegetables overall much more frequently than fruits, and primarily at lunch and dinner meals. And schools provided a large amount or portion of children's daily fruit and vegetable intakes. But the majority of children are consuming below the recommended amounts. So our study is not without some limitations, but there are also some strengths. So because we used a single day's intake, and it was reported data, it's therefore prone to systematic and random errors. And because, again, this is reported data, we didn't wait, so it's really an indirect assessment. And we did not include juices. So fruit or vegetable juices were not captured or documented here, but we did check the data for the beverages and found that less than 1% were reporting consuming unsweetened juices. And even so, they were not able to clearly indicate, in fact, if it was sweetened or not. Strengths, though, we pre-tested the instrument, and we found high repeatability for food type, particularly for fruits and vegetables. We used food models to aid the recall to ensure that we're sure what they were describing. And it's providing baseline data for this age group for Jamaican children. So from our study, what can we recommend? Well, we recommend offering larger servings of fruit and vegetables to children as they're dependent on us to provide it, a larger variety and frequency, particularly at the lunch and mealtime, and to increase their awareness and exposure to various types of fruits and vegetables. From an environment perspective, we're seeing that PATH is a good template, school meals are a good template, so to continue to encourage it there. It can be increased as well from lunch kits carrying from home, and age-appropriate exposure in the school curricula, whether through farm gardens, trips, home economics, and then policies that promote parent and community involvement, because there are challenges sometimes with fruits and vegetables, but if we have a policy, it makes it that much more enforceable. And we already have school nutrition standards that are underway, being used, and a policy that is also being developed. So hopefully this can be a part of the execution of that policy. So in conclusion, children are consuming inadequate amounts of fruits and vegetables, but a comprehensive school nutrition policy, it does provide a unique opportunity to improve and support their intake of fruit and vegetables. So we'd like to thank our collaborators from the University of North Carolina, from Bluebird Philanthropies for funding, and the study participants, the facilitators, the teachers, the parents, the children for participating, giving of their time, and the Ministry of Education and Youth for facilitating the participation of the schools. Thank you very much.
Good morning. So today I will be presenting on food marketing and health promotion exposures in Jamaican primary and secondary level schools. So what is marketing? Well, marketing can be described as the act of promoting the buying and selling of a product or service. It is important to note that marketing can be very pervasive, especially the marketing to children. We find that it comes through many channels, such as the TV, radio, packaging, and even in schools. This is really a problem for children, as there is a direct causal relationship between children exposure to marketing and obesity. When children are continuously exposed to unhealthy food marketing, they develop unhealthy eating habits and food preferences, which can lead to numerous health risks such as obesity and NCDs. The food and beverage industry targets children by marketing where they mostly congregate, using child-appealing graphics, and even offering incentives. These kinds of marketing are so harmful that the World Health Organization recommends a stronger policy that reduces children's exposure to harmful impacts of food marketing. So our objectives were assessing the food and beverage industry marketing exposures in and reports of donations in schools, but also assessing health promotion exposures. We also wanted to document the presence and type of marketing techniques used in advertising food and beverage products. So this study forms part of a larger study, the Jambar Kids Project, where 54 primary and secondary level schools participated. We conducted interviews with the principals and food managers, where we received reports on sponsorships and donations within 12 months of the study. We also did an audit checklist, where we captured the presence of all marketing elements. We also took photos of these elements and then used a tool to analyze the marketing techniques. So just to give an example of what elements and techniques are, on the right you can see that elements are billboards, wall wraps, branded equipment, even posters, and even branded staff apparel. The techniques are things that they would use to lure people into buying their, or even people and children rather, into buying their products using bright colors, cartoon characters, even health claims and games. These techniques are can also be printed on the elements, as you can see. So now I'll describe my results. So this slide is showing what the schools received from the industry, from food and beverage industries. So sponsorships and donations. The darker column is showing that overall that 65% of schools received one or more donation in the previous 12 months. And the lighter blue columns is just a breakdown of that darker blue column. So these are just the top 5 reported donations. So school meals, educational equipment, food service, COVID sanitation, branded apparel. I should also mention that in the larger study, we saw that around 76% of schools had branded food service equipment already present in the school. So here now we have a breakdown of the number of schools having different types of marketing elements, whether it was inside or outside of the school. So inside is blue, outside is yellow. Most elements had company logos, and this is just an indication of how prominent company branding is. It is important as it is a method that is used to drive brand recognition. So just below logos, we see that, well, we found mostly kitchen appliances, staff apparel, posters, brand, and banners with building wraps. So we mostly found that inside of the school. While outside, we had building wraps, billboards, posters, and equipment. This slide shows the distribution of what was being marketed or promoted on the elements. So overall, we saw that around 58% was health and safety, but it was really limited to COVID safety measures, while physical activity was very low. For the food and beverage, we saw that the majority of the marketing was unhealthy food, and that non-essential was 17%, sweetened beverages was 14%, and fast food was 4%. So when capturing the presence of the marketing logos, the marketing techniques on the food and beverage elements, a tool with over 40 different techniques was used. What we are currently presenting, or what I'm currently presenting, is the 9 most frequently occurring techniques. So for the darker blue bars, I just want to note that general marketing means that it's marketing to both children and adults. So it can appeal to either. And for the child appealing marketing, which is the lighter blue, we see that it is only appealing to children. So for the darker blue, we see that almost 100% of the elements had logos on it, and that about 52% of the elements was promoting flavor and texture. We're now looking at the lighter blue columns that is child appealing, and we saw that the presence of child appealing graphics was there, coolness, social media, we had cartoon characters, even the promotion of unconventional flavors, and even appealing to fantasy and adventure. So in summary, there appears to be a lot of marketing and promotions of unhealthy foods and beverage in schools, mostly where children congregate, with the use of very prominent child-appealing techniques through different channels, such as donations and staff apparel. Yes, health promotion was extensive, but it was only limited to COVID-19 messages. And with every project, there were some limitations, and with mine, we had that the sample may not be a representative, as some schools did not allow us to take pictures within their walls. We were also unable to cost the sponsorships that were reported, and it's post-COVID. It was a post-COVID study after a very long period of school inactivity. So what are our recommendations from these results? Well, I would recommend the removal or restriction of children's visibility of food and beverage industry marketing elements. So that would be the posters, removal of it, and staff apparel. Develop protocols around donations and sponsorships, and diversify and promote health marketing strategies. In conclusion, children in Jamaican schools are exposed to unhealthy food and beverage marketing, especially at sales location via industry donations, including food marketing safeguards in a comprehensive school nutrition policy is recommended. So I would like to take the time to acknowledge our research partners at the University of North Carolina at Chapel Hill, our funders, Bloomberg Philanthropies, and we are especially grateful for the contribution of the volunteer schools and staff and the children in the Jambar Kids project, and continued support of the Ministry of Education and Youth. Thank you.
Thank you very much, Ms. Gray-Brown and Ms. Findlay. Just plain devil's advocate. The people who produce unhealthy food and drinks market it successfully. Why don't the people who make healthy foods and drink market their food? Can we put our hands together again for the presenters? All right, so we take our questions and answers at this time. Do we have any questions online? Yes, could you just go ahead and read? Could we get her a mic?
Question for Mrs. Gray-Brown. Do you think involving students in backyard farming at home and at school will encourage them to eat more fruits and vegetables?
Please repeat, thank you.
Do you think involving students in backyard farming at home and at school will encourage them to eat more fruits and vegetables?
Yes, great question, and definitely. When they're involved in it, then there's some degree of ownership. And if they see it grow, then they'll perhaps want to taste it and be a part of cooking it. So yes, for sure, definitely.
Okay, is there any plan for replicating the study in other parishes, particularly in those schools that are in more rural areas? And was there a difference in fruit and vegetable consumption in public versus private schools?
All right, great question. So in terms of replicating, I can discuss with our principal investigator, Dr. Suarez Winter, because that requires budget and funding. But there will be additional phases, and I know she does have the interest, so once we can secure the funding, then definitely, I know she would work on that. In terms of differences between public schools and primary schools, we checked, and we did not find any. At this stage, the differences that we found were really based on the location, whether it was school or other sources.
Okay, and is there a link between the consumption of fruits and vegetables and their affordability?
A link. Okay, so that is basically asking if we found differences between income. So the proxies that we used for SES were the income level of the parents, and it was basically if it was above or below minimum wage. We did not find any significant differences. Perhaps with further analyses we can elucidate, but with what we did not find those differences. But in general, though, we do know that sometimes a healthier option may be more expensive. Not always. For example, a banana does not have to be more expensive than a banana chip, but depending on what we're going for, it can sometimes be more expensive. But in our studies, we did not see those significant differences. Okay, thank you.
Mr. Wright? So the question for you is, glutathione has been mentioned in many studies in the US that claim to reverse diabetes mellitus type 2. Will this be made available even for trials to our population?
To our population? That's a very interesting question. I must say, I don't know. But based on my findings, would I recommend glutathione? I think yes. Glutathione supplements are already on the market. As simple as Amazon, I think you can get 60 capsules for $20 US. So they're available. I mean, the process of implementing it in Jamaica would have to go through ethical approval and all of those steps, but I think so.
Yeah, just wanted to ask one question or two. How do you get the number of grams from just asking the children? Yeah, or number of grams of fruit. I was wondering how you did that.
Okay, great question. So let's say we have a banana, right? And let's say they said I had a ripe banana. We would assume, based on the food models that we used, that if we said, is it like this, and they said yes, and we're using food aids, then we'd match that up with a food database. So for example, the United States has a database, it's called Food Data Central, and they will have different sizes of fruits and the weights that accompany them, and then we'll be using the edible weight. So it's really using the food aid to say, is it about this size? Yes, miss, no, miss. And then we match it up with the food database and assume the edible weight, not the seeds and so on.
Okay.
Thank you.
Thanks. And just one more for this man here. I'm very interested in glutathione because I'm actually working with a product that uses glutathione. What I wasn't familiar with was the nitrosoglutathione and the whole possibility of nitric oxide being able to be utilized from that. I mean, it's amazing. How do we get nitrosoglutathione? How do you get that?
Could you repeat the last part of that?
How do you get nitrosoglutathione? Where do you get it from?
Where do you get it from?
Yeah.
So it's a compound that is produced in the body. So what happens is that in order to store, it's like a pool for nitric oxide. So it reacts with glutathione to form S-nitrosoglutathione. So it's just the attachment of NO to the sulfur atom of glutathione. So that H hydrogen is replaced with that nitric oxide. So it is produced in the body. I guess it's more so in terms of, they have supplements for nitric oxide that utilize arginine and citrulline. Arginine is a substrate that is used in the body by a set of enzymes, and then in that reaction it produces nitric oxide. So they have those that basically will increase nitric oxide concentration, and I guess that would facilitate reaction with glutathione. However, the drawback is that we have to ensure that the nitric oxide concentration doesn't reach cytotoxic levels. So that's why in our study we use glutathione in excess compared to the S-nitrosoglutathione. So yeah, it is in the body.
Okay, thanks.
Thank you. I saw Miss Dr. Dawson with her hand up. And Ms. Gray-Brown said that children are getting consuming adequate fruits and vegetables. And I wonder, even if the vegetable is fries coming from the burger? Oh, inadequate. Oh, all right. Go ahead, Dr. Dawson.
Okay. Good morning, everybody. Excellent presentations. I am very pleased. I can see the next generation of nutritionists and dietitians along with our biochemistry team. Now, just a quick question. Ms. Finley, how were the schools chosen? How were the schools? Well, how were the schools chosen?
So they were just randomly selected. So it was in Kingston and St. Andrews, so there was just a number of schools that were randomly selected.
Randomly based off whether they were willing or not, or just random?
Can you repeat that?
Random based off whether they were willing or not, or just?
So, yeah, well, they would have participated if they were willing, but we had a number of schools, again, that was just randomly selected.
Pulled from the pool
those
of?
persons, the ones that are currently a part of this study, gave us permission, so that would have been factored in.
Okay. And just a quick other question. With regard to the billboards, they were actually placed in the schools, on the walls, on the...
So we had posters that we found that were placed inside of the school. I didn't exactly say this part, but they were mostly found in the canteen and in the tuck shop. So we would find posters, stickers, maybe along the wall, along the corridors, and then the billboards would be outside of the school. So we would find that we had posters that were billboards that were maybe right in front of the school or just a few steps beyond the school gate. So hopefully that answered your question.
Yes.
Is it okay?
It did. Thank you.
Okay, you're welcome.
Okay, so we had Annetta Gordon, Amelie Wright, Annalie Gray-Brown, and Laura Gay Finley. Can we give them a round of applause? And this brings us to the end of session 3. And I'm going to ask our presenters to stand.
Before we close this presentation, we want to just say a word of thanks to Mr. Williams for ably taking us through this session. Thank you so much for your moderation. Thank you. Good afternoon, everyone. We are going to begin our next scientific session, which is on the impact of communicable diseases. My name is Dr. Andreen Grant, the Director of Epidemiological Research and Analysis within the Ministry of Health. No, I am not Dr. Nadine Williams, so I am apologizing on her behalf. But we go ahead with, again, a very interesting and intriguing session. So our three presenters are Mr. Jovan Wigan, Dr. Georgiana Gordon-Strawn, and Dr. David McGowan. And so I will do the introductions of our three presenters first. Mr. Jovan Wigan is the Epidemiological Officer in the National Epidemiology Branch. He has provided significant contribution to the national epidemiology response to COVID-19, especially in relation to complex data analyses and data visualizations. Mr. Wigan was integral to designing charts and graphs to depict chains of transmission of cases in the early phases of the pandemic, as well as wave charts to predict the severity of different COVID-19 surges. As a member of the COVID-19 research team, he cleans, analyzes, and reports on surveillance data and contributed to documents for publication related to COVID-19 outcomes and transmission. Dr. Georgiana Gordon-Strawn holds a PhD in biochemistry from the University of the West Indies and a Master of Science degree in health policy, planning and financing from the London School of Hygiene and Tropical Medicine, the University of London. She is currently employed to the Caribbean Institute of Health Research, where she serves as Director of the Tropical Metabolism Research Unit. Dr. Gordon-Strawn is the Executive Director of the Regional Center for Small Island Developing States of the Lancet Countdown for Health and Climate Change. Finally, Dr. David McGowan is a graduate of the University of the West Indies, Mona, and a consultant internist at the Cornwall Regional Hospital with special interest in infectious diseases. His research interests include antimicrobial stewardship, HIV, hepatitis, and tuberculosis, and quality of care. A clinician educator, Dr. McGowan has keen interest in medical and health education. Let us give them a round of applause. And so we will begin with our first presentation by Mr. Jovan Wigan, and it is entitled Time to Viral Clearance of COVID-19, Analysis of National Surveillance Data, Jamaica. Mr. Wigan.
Good afternoon, everyone. I'll be presenting on the time to viral clearance of COVID-19 analysis of surveillance data in Jamaica. So, the first reported case of COVID-19 in Jamaica was on the 10th of March 2020. Now, just to look at some more recent figures, as at October 22, 2023, over 771 million confirmed cases of COVID-19 have been reported globally, with over 6 million deaths, while locally there was a cumulative total of 156,643 confirmed cases and 3,712 reported deaths to the National Surveillance Unit. Now, viral shedding is defined as the detachment of the virus from the body secretion, excreta, or service, which might lead to the spread of the viral infection. So this essentially means that once the virus in the body multiplies to a certain point, it is then released into the environment either by sneezing, coughing, or even simply speaking, wherein if it comes in contact with someone else, then it causes spread. Viral shedding is also identified through PCR testing of the respiratory tract specimens. And the time to viral clearance is the period from the first positive nasopharyngeal test to the first of 2 consecutive negative tests. As at the 12th of January 2020, the WHO had initiated recommendations for allowing patient discharge from isolation through the use of viral clearance. However, in May of 2020, they had updated this recommendation to shift from the use of the 2 negative PCR tests to a minimum time in isolation of 13 days in symptom of onset. So if you had symptoms, you'd have spent about 13 days in isolation, after which you'd be assessed and either released, or if needs be necessary, they would extend the time. There is limited information on the time to viral clearance of COVID-19 in the Jamaican and the Caribbean context. However, studies have shown that prolonged viral shedding has been associated with an increase in age as well as greater disease severity, whereas in terms of the association with sex, for the most part, most studies have found that it's been associated with being male, while some studies have not found any sex differences. So the objective is to estimate the time to viral clearance of COVID-19 occurring from March to June 2020 using the national surveillance data in Jamaica. Now, the study, it's a cross-sectional analysis of national surveillance data. We looked at cases with confirmation dates from March 10 to July 31, 2020. Now, this would have been early on in the pandemic during the pre-community transmission phase, where cases would have been sporadic and eventually you'd also have some clusters. Now, we also looked at cases with 2 consecutive negative SARS-CoV-2 PCR tests with the first test date prior to June 19, 2020. However, you might wonder why June 19. Well, the recovery and discharge protocol for the confirmed cases, which required the 2 negative tests, was changed on June 19, 2020, which have been in keeping with the WHO recommendation as mentioned earlier. So the time to viral clearance, the time in days from the first positive nasopharyngeal swab to the first of 2 consecutive negative tests. A confirmed case is a person with a positive PCR test irrespective of any clinical signs and symptoms. And for the clinical severity, persons were classified as being mild, moderate, or critically ill based or severe based on the WHO disease severe case categorization. In terms of the statistical analysis, looked at frequency distribution of cases. We computed the median and interquartile range for the time to viral clearance. We used the Kruskal-Wallis and Mann-Whitney test to evaluate differences by age, sex, and severity. A p-value of less than 0.05 was considered statistically significant, and we had used Theta SE version 16.1 to conduct the analysis. In terms of, so going into the results, in terms of the selection criteria for the cases, we started off with 881 cases between March 10 and July 31, 2020. 450 of these cases were excluded because they did not have the 2 consecutive negative tests, and the first test date was on or after June 19. Because as I mentioned before, the protocol had changed at that time, so that would have eliminated a large amount of our cases. So we're left with 431 cases for the analysis, which had the 2 consecutive negative test dates, as well as the first test date being prior to June 19, 2020. Now, just to give a description of the cases, in terms of sex, 58% of the cases were female, 42% were male, 93% were under the 60 years of age, while 77% were 60 years and over. In terms of the severity, 54% of the cases were asymptomatic, 43% mild, 2% moderate, 1% critical. Now, this is just a table showing the brief summary of what I mentioned before. We had also looked at age in terms of 10-year age grouping, where 40.8% of the cases were 20 to 29 years of age. In terms of the median time to viral clearance, the overall median time was 28 days, in terms of sex, females had a longer time to viral clearance than males. Cases under 60 years of age had a longer time to viral clearance than those 60 years and over, and mildly ill cases had the longest time to viral clearance. And these are just some charts showing the median times to viral clearance. As you can see, females having a longer time than males. In terms of the severity, the mildly ill cases had the longest time, followed by those that were asymptomatic. In terms of age, those under 60 had the longest time. By 10-year age grouping, those 10 to 19 had the longest median time to viral clearance, followed by those 20 to 29 and 50 to 59 years of age. Prolonged viral shedding has been associated with increasing age and greater disease severity, while mixed findings have been observed by sex. For this study, the time to viral clearance was longer in those under 60 years of age, females, and in mildly ill cases. Sensitivity analysis was conducted showing the time to viral clearance with and without the presence of a workplace cluster, wherein that workplace cluster had a median age of 26 years, and it showed that the cluster had a longer time to viral clearance compared to the remainder of the sample. It is also important to note that a positive PCR test could be due to viral fragments being present in the original infection and may not indicate active viral replication. Strengths and limitations. This study indicated that the treatment time from diagnosis to isolation of COVID-19 in the Jamaican context. A strength of the study is also the fact that robust contact tracing was done early in the pandemic, so data available on persons with different clinical severity. The data used had a limited number of cases as it covered a short timeline. As mentioned before, it was within the pre-community transmission phase of the pandemic, and due to the change in the recovery protocol, we lost 450 cases. Due to the use of surveillance data, there may also be issues with underreporting, lack of representativeness, and timeliness. In conclusion, the study found differences in time to viral clearance by sex, age, and clinical severity. However, more viral clearance studies are needed to guide response in future public health events. Thank you.
Let's give another round of applause to Mr. Wigan. At this time, we are going to go to our second presenter, and that is Dr. Georgiana Gordon-Strawn, and the title of her presentation is The Impact of COVID-19 on Maternal Mortality in Jamaica.
Thank you, Dr. Grant. I have a slight challenge in that I can't see the screen, but I have it on my iPad, so I think we can go through quickly. Thanks for that kind introduction, and thank you to the Ministry of Health for giving me the opportunity to present this first kind of look at the impact of COVID-19 on maternal mortality in Jamaica. So the authors declare no conflict of interest. The study was funded by the Planning Institute of Jamaica, and ethics approval was obtained from both the University of the West Indies and the Ministry of Health and Wellness. So just by way of background and to set the context, let's just start with a few definitions. So maternal mortality, as defined by the World Health Organization, is the death of a woman while pregnant or within 42 days of termination of the pregnancy. And this is irrespective of the duration and the site of the pregnancy. Maternal mortality is measured as a ratio called the maternal mortality ratio, and it is the number of maternal deaths per 100,000 live births within a given period. In 2020, the global maternal mortality ratio was estimated by the WHO at 223, with the highest ratios found in sub-Saharan Africa and for the Caribbean in Haiti. Globally, maternal mortality has been trending downwards. WHO estimates for 2020 show an increase in the region of the Americas, in Jamaica and the USA, suggesting that the COVID-19 pandemic may have contributed to the increase in the number of maternal deaths. Now, we all know about COVID-19, and we know that the first case was recorded in Jamaica in March of 2020, and several measures to control and to slow down the spread of the pandemic were enacted. These included stay-at-home orders, closure of schools, closure of non-essential business, physical distancing, and mandatory mask wearing. By December of 2021, Jamaica had recorded 93,591 cases with 2,470 deaths. And by the end of October 2023, our numbers were 156,433 cases and over 3,600 deaths. So this study sought to pull the two together, and the objective was to determine whether or not COVID-19 had an impact on maternal deaths by comparing the causes of death and the maternal mortality ratio for two periods: a pre-COVID period, which is the 2 years, essentially 2 years prior to the pandemic, and 2 years, the first 2 years of the pandemic. So our pre-COVID period was January 1, 2018 to December 31, 2019, and our COVID-19 period was January 20 to December 2021. Now, the WHO has 3 categories of pregnancy-associated deaths. They are direct or indirect maternal mortality, again in a pregnancy, and during pregnancy, and up to 42 days after the pregnancy ends. They also have late maternal deaths as one classification, and other pregnancy-associated deaths. For Jamaica, we monitor both, but for this presentation, I will only be looking at maternal deaths and mentioning a little bit about other pregnancy-associated deaths, specifically looking at external causes like accidents and violence. I'm sorry, I went over. So we had 2 main data sources to pull this information from, and our analysis is secondary data analysis. So deaths that were registered to the Registrar General's Department and those recorded in the Ministry of Health and Wellness's Maternal Mortality Surveillance System were combined into one master list, was cleaned, and the causes of deaths coded using both the WHO guidelines for maternal deaths and the COVID-19 guidelines for classifying and coding COVID-19 deaths. We looked at this and compared it during the pre-COVID period, which I will call the reference period, and the COVID-19 period. And we analyzed this information by age, health region, WHO type, and underlying cause of death. So, findings. We found a significant increase in the maternal mortality during the COVID-19 period. The MMR for Jamaica increased from 135.4 per 100,000 births in the 2 years prior to the pandemic to 170.6 during the first 2 years of the pandemic. 47 deaths were classified as being COVID-19 positive, of which 42 were responsible for indirect causes of maternal mortality. Okay. So using the WHO's guidelines, we found that there was a significant increase in indirect deaths during COVID-19, increasing from 24% to 47% of all deaths. However, the direct causes of deaths actually decreased from 59% pre-COVID to 46% during COVID. When we looked at age, we found that women who were 35 and older had reported the highest maternal mortality for both periods. However, the largest increase in maternal mortality was found among the 25 to 29-year-old age group. Interestingly, the under 20 age group had a significant reduction in maternal mortality. When we looked at it by health region, you can see here that the region with the highest number of deaths attributed to COVID-19 was the southern region, and they're to the far right of the chart. And I'll just skip on to say that both the western and southern region recorded the highest levels of maternal mortality and attributed to COVID-19. When we looked at the direct causes of deaths, we found that everything decreased except for obstetric hemorrhage, and this was significant. When we looked at indirect causes, of course, COVID-19 came out with much higher numbers, contributing 61.4 to the MMR for Jamaica. I told you before that we looked at accidental and violent deaths, and we found that there was a decline in violent deaths, a significant decline, and this was quite surprising, but also quite refreshing. So I'll go straight to my key findings. Compared with the non-COVID period, the MMR increased from 135.4 to 170.6. The COVID-19 attributable MMR was 61.4. In other words, COVID-19 was responsible for more than 36% of all our maternal deaths, so more than a third. There was a significant increase in deaths in the 25 to 29 years age group, and the southern region experienced the largest increase in MMR. With the exception of obstetric hemorrhage, there was a decline in direct deaths, and all non-COVID indirect deaths showed a decline. And as I said earlier, there was a significant reduction in violence-related deaths as a cause of coincidental deaths. So the increase in obstetric hemorrhage has been shown by other authors, and their explanation is that it causes a coagulopathy that may explain the increase seen in obstetric hemorrhage. One study by Janosowski found that patients, pregnant women with COVID-19, had a longer activated partial thromboplastin time, a reduced prothrombin time, and lower platelet count. And it was also associated in that study with a higher frequency of postpartum hemorrhage. The decline in all indirect causes of maternal deaths also needs further investigation, and it is unclear to us why the 25 to 2019 year age group was disproportionately affected. The decline in violence was not supported by other studies, such as those done locally, one by Capri, and another that was done by the UN, which was authored by Yen Ilmez. So just to talk about one limitation of the study is that we utilized secondary data, and so we were not able to probe the driving factors behind these deaths. So one recommendation for us is that additional research is needed to elucidate the reasons for these deaths, and this may be done using an established model called the 3 delays model to determine what underlying factors caused these deaths. So for example, for obstetric hemorrhage, was the cause because of a lack of blood, or was there another cause? And what are these factors? So in conclusion, the COVID-19 pandemic adversely affected Jamaica's MMR, and an MMR of 154 represents an upward trend from the 1998-2003 MMR of 92, and with that, our commitments to the Sustainable Development Goals, we may not be able to make this goal of 70 per 100,000. I'd like to acknowledge all the persons who helped with funding or collecting the data, and these include the Registrar General's Department and the Epi and Data Analysis Unit of the Ministry of Health. And I thank you.
We'd like to thank Dr. Gordon-Strachan again for her presentation. And we now move to the next presentation by Dr. David McGowan, and it is entitled A Cross-Sectional Survey of Antibiotic Use Among Patients Admitted at 2 Urban Hospitals in Jamaica. Dr. McGowan.
Thank you and good afternoon. I'm a bit concerned that this is not the right version, but we will go ahead anyway. I would like to say thank you very much for allowing us to present. And on behalf of the team of Dr. Spate Robinson, Ferguson, Thorburn, Mitchell, Headley, Prout, and Thompson, I'd like to present the data for a cross-sectional survey of antibiotic use among patients admitted to 2 urban hospitals in Jamaica. This work was done as part of the requirement for my clinical fellowship in infectious diseases. So I do want to say that we had made some edits to this. I don't think this is the edited version, so I may have to make a few corrections. But the World Health Organization has identified antimicrobial resistance as a threat to global health and development. Antimicrobial resistance is one of the top 10 global public health threats facing humanity with significant economic impact. And the CDC, the US CDC, has documented their annual cost from antimicrobial resistance to be about $55 billion US, 20 billion of that in medical costs, health costs, and 35 billion coming from loss of productivity. Antimicrobial misuse and overuse were among the main accelerators of antimicrobial resistance. So antimicrobial stewardship by coordinated efforts to promote, assess, and improve appropriate use of antimicrobials can reduce antimicrobial resistance. There is limited data on antimicrobial use and stewardship in Jamaica. Point prevalence surveys provide an opportunity to assess antimicrobial use and improve antimicrobial stewardship. Now, many hospitals do not actually have stewardship programs. In this study as background, University Hospital does have an established stewardship program, and Cornwall Regional does not. So on that background, we sought to estimate the prevalence of antibiotic use at the Cornwall Regional Hospital and University Hospital of the West Indies to evaluate antibiotic usage patterns and antimicrobial stewardship, looking at specific indices, and then to estimate the direct costs for antimicrobial use at the 2 hospitals. So a cross-sectional clinical chart review was done involving 368 inpatients at University Hospital and Cornwall Regional on specific days between August 2021 and January 2022. Data were extracted using a project-specific questionnaire. Analysis was done using status 17, and prevalent antibiotic use was defined as being administered at least 1 antibiotic during the surveyed day. So, in terms of participant data, we had 56% females overall. At University Hospital, that was 66%, and at Cornwall Regional, 49%. In terms of mean age, it was 44.89 years, and the median number of days admitted was 8. I just want to make an amendment. The correction to the p-value there should have been 0.639. So there's some of the errors that we corrected along the way that didn't get here. So I do apologize. In terms of those who are on antimicrobials, we had a total of 54% overall, 57% at University Hospital, 51% at Cornwall Regional. When we looked at antibiotic use by class, we found the most commonly used class was the cephalosporins. And they were, as you see, they are approximately 28 to 30% of the group. What was statistically significant was aminoglycoside use, the difference between the 2 institutions, with more aminoglycosides being used at University Hospital. And fluoroquinolone use had a trend towards significance, which we thought was attributable to the fact that fluoroquinolones are restricted at University Hospital and not at Cornwall Regional. About 30% of the population had 2 or more antibiotics. This is just a bar chart illustrating similar principles. You can see that the cephalosporin group was the most commonly used across the 2 institutions. In terms of antimicrobial stewardship indices, the ones that were statistically significant were cultures being done, and that's any antimicrobial culture being taken. And we see a difference there between 50% at the University Hospital and 29% at Cornwall Regional. In terms of antibiotic review date being documented, again, a difference in favor of 11% at the University Hospital and 2.9%, 3% at Cornwall Regional. And evidence of de-escalation was 8%, well, 4.9% at the University Hospital and none at Cornwall. And de-escalation would mean, for instance, going from a cephalosporin to a penicillin, or carbapenem to a penicillin, or 2 or 3 antibiotics to 1. Sorry. I just wanted to also point out that what you're not seeing at the bottom of the chart is indication documented, and for all the centers, indications were documented and pretty well done. Where we have more work to do is in documentation of stop dates for antibiotics and in raising our numbers of culture-directed therapy. So you can see the numbers, even though there are more cultures than the culture-directed therapy is only about 12%, 13% of your population. So that's something that can be worked on at both institutions. In terms of cost analysis, this is what we did. We did a direct antibiotic cost, and I'm going to illustrate it using ceftriaxone. We determined a daily dose. In this case, 1 gram IV daily. You had a unit dose cost at the University Hospital and at Cornwall. Based on the number of patients in the study, we determined a daily cost for University Hospital and a daily cost for Cornwall Regional. And these are costs to patients as provided by the pharmacy staff. And the annual cost for UE is documented there, and we had an annual cost for Cornwall, which was calculated basically taking the daily cost by 365. And so overall, we had an annual cost in US for ceftriaxone of about $97,600. Overall, the direct cost for antimicrobials is estimated about 1.78 million US, which is not an insignificant number. So the limitations of this study was conducted during the COVID-19 pandemic and was impacted by reduced staffing levels, restrictions in admissions and movement. And for instance, during this period, both institutions, the surgical services were only doing emergency admissions. Pharmacy data provided by the institutions was potentially affected by the source of medications, use of branded versus generic drugs, and relative purchase volumes. In conclusion, approximately half of the patients admitted to UHW and Cornwall Regional received antimicrobial therapy. Cephalosporins were the most commonly used antibiotic class, and antibiotic use carries substantial direct costs. We hope that this will form a foundation for improving stewardship both at University Hospital, but also at Cornwall Regional, where we're hoping to establish a stewardship program shortly and possibly roll it out to other hospitals across the country. I'd like to acknowledge the clinical research team, my academic advisors, Professor Boyne, Professor Brendan Bain, Dr. Alison Nicholson, Mr. Anthony Myers for his IT expertise in creating our questionnaire and the data extraction process. And I wanted to acknowledge the medical and pharmacy students who assisted in data collection. And I thank you. I'm willing to take any questions.
Let's have another round of applause for 3 excellent presentations. And at this time, we want to open the floor for questions. We will begin with the online platform. Are there any questions online? Are there any questions for our presenters in the room? Yes?
Good afternoon, everyone. Excellent presentations. I have a question for Mr. Wigan. You know, it was interesting to see the viral clearance, and specifically to see that in females it took a longer time to clear, and also for the persons who were mildly ill, that it took the clearance took a longer time. From reviewing the records, or I'm not sure if you saw the records or just data, was there anything that you picked up that would have contributed to that, or from your readings?
As a possible reason as to why the females, what I'd say is that, as I'd indicated before, that we had done some sensitivity analysis in relation to a workplace cluster. Well, in terms of that cluster, most of those cases were actually female, and most of those cases were actually asymptomatic and mildly ill. What I could say is that in terms of looking at the workplace cluster versus the other sample, I'd rather call them the non-workplace cluster cases, the workplace cluster actually had a median time to viral clearance of about 33 days, whereas the non-workplace cluster cases had a median time of about 20 days. Whereas the overall time was about 28 days. As a possible reason as to maybe why that might have been, is that very early on in the pandemic, due to the robust contact tracing, the workplace cluster cases, they would have been identified very early on where they were in a state of maybe being asymptomatic or pre-symptomatic. Therefore, they would have eventually had a longer time to viral clearance, as opposed to maybe those who were identified as when they were already in a symptomatic state. I hope that answers the question.
Thank you.
Okay.
Are there any further questions in the room? Or any questions online? I have a question for Dr. Gordon-Strong, given the implications of the findings with respect to maternal mortality. I was just wondering, what are the next steps in terms of sharing the data and the policy implications that will arise from the findings?
So in terms of sharing the data, I think that, as I said, this study was funded by the Planning Institute of Jamaica, but I don't see why the data can't be shared. The majority of the data came from the Ministry of Health's data sets. I think you already have most of it. In terms of policy implications, I think that during COVID, many things happened, some of it really, really well. We did really well on some things, and on other things, we were not able to manage as well. And from my own perspective, I think in order to come up with policy recommendations, a deeper dive is needed into why these deaths actually occurred. So my own recommendation would be to do something similar to what's done in the UK, where they do a confidential inquiry of maternal deaths. And this is done at routine intervals, like maybe one every 10 years or so. And because COVID-19 was such a special time in the life of the world, such an investigation, I think, would be timely, and from that, recommendations could be made. But I also want to just draw your attention to the fact that a lot of our deaths happened in the age group 30 and older. So that has implications, even without COVID-19, for the delivery of systems and how we may restructure or reorganize our health system to facilitate this older pregnant woman who may come with other comorbidities that would have started to appear by the time she's 30.
I know that I can't, I'm not sure who is going to be handing who the basket because I can't hand it to myself. But are there any further questions? Yes, go ahead.
Sorry, I have a medical knee problem, so standing. Dr. Gordon Strawn, are there any plans to look at vaccinated pregnant women and the mortality after the vaccination?
Well, that's certainly something that can be looked at. The data set we had didn't look at vaccination or didn't measure whether or not the women were vaccinated, but that's something that can be looked at. Other studies that I've looked at where they've done a systematic review of the literature, they haven't found that connection between women who are vaccinated and any kind of morbidities that show up later on with COVID-19. But it's still early days, even though it's, quote unquote, almost over. And I think some of the implications won't be seen until later on, or we won't be able to appreciate them until later on. Thank you.
All right. I have a question for Dr. McGowan, not you, Dr. Strawn. All right. So, Dr. McGowan, thank you for your presentation. I heard you mention that there was a class of antibiotics that was restricted at UWI. Was that the fluoroquinolones?
Fluoroquinolones.
Could you say why?
Are restricted as well. So, in general stewardship principles, we tend to restrict antibiotics that are determined to be of either high value or crucial use. Fluoroquinolones are, and that would be things like ciprofloxacin, levofloxacin, as oral agents are one of the key anti-pseudomonals that we have in the community. So with wanton use in the community, you find you get a lot of resistance. So periodically they will restrict antibiotics so that you won't have an overuse within the hospital system. And actually the resistance goes down a lot of times when you do that. So they have attempted to improve stewardship by restricting certain classes. So carbapenems are restricted and fluoroquinolones are restricted as well.
All right. Thank you for that response. So that's something we maybe need to be looking at in the public health sector.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablet. Yes, you should. We need physical activity. Well, that's what adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for the pressure. Do you know what will lower your risk of depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now, we're gonna do the basic step. To the left, take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees. Hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
Is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Do your part to prevent mosquito breeding. Mosquitoes will breed in any container that holds water.
Tightly cover water storage containers such as drums, barrels, buckets and tanks. If this cannot be done, pour cooking oil on the water surface. Punch holes in all tins, plastics and beverage boxes to prevent the collection of water before disposal. Cover all tires or fill with dirt to prevent water collection. Scrub all vases once per week to remove mosquito eggs. Use mosquito repellents to protect yourself from mosquito bites. Dispose of garbage properly by placing in plastic bags and securing properly to prevent water collection.
A message from the Ministry of Health and Wellness.
Come pre this you, don't pre that, let me tell you about the body and some physical facts. Come pre this you, don't pre that, let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy, better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something, yeah man, listen young youth. Physical activity, healthier weight, go and exercise, students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents, physical activity is of the essence. Needed like full stop in any sentence. Come pre this you, don't pre that, let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. I does the 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Love your body, treat your body right. Love your body, treat your body right.
The Ministry of Health and Wellness is celebrating Caribbean Wellness Day 2023 with a weekend of wellness. Saturday, September 9. All roads lead to the University of Technology, Jamaica for a sweat fest. 4 p.m. to 8 p.m. Join the 3K Fun Run Walk. Pass through the obstacle course and work up a sweat with the Sweet Energy Fitness team. Admission free. No sign-up required. Lots of prizes and surprises along with free food samples. Come, get it Jamaica Moves shirt. It's a weekend of wellness. Wow, with the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Protect yourself from the bite of this mosquito.
A message from the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Search for its breeding sites and destroy them.
A message from the Ministry of Health and Wellness.
good ganja sense. Learn more your ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Knowledge is power, youths we need that. Ganja smoking and no pitney thing that. Commercial ganja you farm then you reap. Entrepreneurs and scientists see. Good ganja sense, learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Be smart with your ganja, go get a permit. Ganja full of uses, make sure you learn it. Can sell eye drops, it make for eyes. Ganja can boost lives. Good ganja sense, good ganja sense. Learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis.
Brought to you by the National Council on Drug Abuse, an agency of the Ministry of Health and Wellness.
We got to be careful when using pesticides.
Alright, Richie. Can I out to mash up some spraying idea?
Yeah, I go spray them corn there.
So, are the tree wearing the protective gear?
Boy, the sun too hot for suit up here, man.
So you did read the label before you start? Wear protective gears. Your goggles, your respirator, your gloves, and a coverall. At least you did have on a cap. Mix only what you need for the day.
Good afternoon, everyone, and welcome to Scientific Session 5. I'm Ardeen Harris, and I'll be leading you through this session. We'll have 3 presenters, after which we'll have discussion and question and answers. The 3 presenters are Ms. Jada Smikle. She'll present on the impact of COVID-19 pandemic on the utilization of Jamaican health clinics. We'll also have Dr. Carol Lord. She'll present online. She'll present on maternal and perinatal outcomes of eclampsia and pre-eclampsia at public hospitals in the Southeast Regional Health Authority, SARA, Jamaica, a 5-year review. And then we will have Ms. Selena Lewis, who will present on association between sleep duration, hypertension, and polycystic ovarian syndrome in women from the UK Biobank, a case-controlled study. So I'll go ahead and introduce the presenters. First, Ms. Jada Smikle. She's a second-year medical student at the University of the West Indies. She holds a Bachelor of Science degree in biochemistry and a master's in epidemiology. Outside of her academic and research pursuits, Jada is the immediate past president and current membership director of the Leo Club of New Kingston. She's passionate about planning and participating in outreach and service projects that improve the lives of the wider community. Ms. Michael. Dr. Carol Lord, who will present online. She is currently the Program Development Officer in the Family Health Unit at the Ministry of Health and Wellness, having served the ministry and the regional health authorities in other capacities. She is in the final stages of completing her doctorate of public health. Dr. Lord has authored research papers in infectious diseases, pediatrics, and maternal health. She is a born-again believer and mother of 2 wonderful young adults who love people. She's passionate about public health, pediatrics, obstetrics, and research. And the third presenter, Ms. Selena Lewis. She's an epidemiologist and research assistant in the Epidemiology Research Unit of the Caribbean Institute for Health Research, currently assigned to the Caribbean and South America team-based strategy to control hypertension, the CATCH study. Ms. Lewis holds a bachelor's degree in basic medical sciences with specialization in anatomy, with first-class honors and a Master of Science in Epidemiology. In 2021, she received the National Scholarship for Mathematics and Science for postgraduates in honor of the Honorable Dr. Mavis Gilmore Peterson. Selena's primary aim is to lead research efforts to enhance our knowledge of polycystic ovarian syndrome. So 3 remarkable presenters, and we'll welcome the first presenter now, Ms. Jada Smikle.
Thank you. Impact of COVID-19 pandemic on the utilization of Jamaica health clinics by Jada Smikle and Georgiana Gordon-Strawn. Conflict of interest, nothing to declare. This study was funded by the Ministry of Health and Wellness as a part of the Essential National Health Research COVID-19 Research Addenda. So for the background, the first COVID-19 outbreak began in China during December 2019. COVID-19 was declared a pandemic by the World Health Organization on March 11, 2020. However, Jamaica reported its first case on March 10, 2020. On March 18, 2020, a state of emergency was declared, and a series of disease control and prevention protocols were implemented. This research falls under the impact of COVID-19 on Health Systems Working Group, a subset of the Essential National Health Research Committee. Okay, so for our objective, to determine the impact of COVID-19 on the utilization of routine type 3 health clinics by comparing a change in clinic visits during the period January 2019 to March 2021. Originally, we looked at 6 clinics: family planning, antenatal, postnatal, child health, psychiatry, and NCD curative clinics. However, for the purpose of this presentation, we'll only focus on 3: family planning, child health, hypertension, NCD curative clinic. So for our method, we extracted patient count data from the monthly clinic summary report for the months January 2019 to March 2021 for type 3 health centers across all parishes. The time period for the study was the pre-COVID period being March 2019 to December 2019, while the COVID-19 reference period was March 2020 to December 2020. However, for the interrupted time series, we based our time period on January 1, 2019 to March 31st, 2021, with the point of interruption being the start of the pandemic in March 2020. For the data analysis, we assessed change in utilization based on patient counts. We generated contingency tables, and patient count was the response variable, and the year was the outcome variable. And we adjusted each variable by parish, age, and sex using 2011 census data. We calculated the percent change in utilization for each response variable and did statistical significant testing using Pearson chi-squares analysis. While for the inferential analysis component, we use Poisson regression since we're using patient count data for the interrupted time series. And we assess each time series for autocorrelation, overdispersion, and seasonality. So just to give you a breakdown of the percentage change in utilization for clinics by health region, we saw that for family planning, the northeastern region reported the most change with an increase by 20.64%, while for child health, we saw a decline across all regions, with western region having the highest decrease with negative 29.09%, while for hypertension, we saw the most change in the northeastern region with 20.6% increase. Here's an example of a model of our Poisson regression through an interrupted time series. So as you can see, for the northeastern region during the pre-COVID period, for January 2019 to February 2020, there was a steady, stable patient count until the light blue line, which indicates the point of interruption at March 2020. Where we saw a decline by 10% in patient visits. The dotted gray line indicates the counterfactual. This would happen if there was no pandemic. Western region, we saw similar results. However, the decline was much difference, which was by 26%. For family planning, the percent change in utilization, we saw the highest change in IUCDs. Similar findings were reported in our time series when we did the national scale, and our incident rate ratio showed a 100% increase as well. So as you can see by the light blue line at the point of interruption, which is the pandemic, there was a sharp increase and then there was a decline. We also looked at the change in utilization for child health visits based on age group. For the age group 7 to 11 months, we saw a significant decline by negative 41.78, also with 24 to 35 months with 45.60, and for 36 to 60 months with negative 30.50. When we did the time series looking at the national data, we also saw a decline at the point of interruption, the light blue line. So as you can see, by the pre-COVID period, there was a steady increase in patient visits. However, during the COVID period, there was a decline. And this was estimated to be 26% by the incidence rate ratio. For hypertension control and uncontrolled, we saw a decline in controlled hypertension and an increase in controlled hypertension. However, when we did the interrupted time series, we saw that there was actually a marginal increase for both hypertension and uncontrolled hypertension at the point of the pandemic. However, it was for a short period of time because it began to decline again. Okay, so for family planning, for discussion, there was an overall increase of 5.7% in the utilization of family clinic services during the first year, 2020 of the COVID-19 pandemic compared with the reference period of March to December 2019. The substantial increase was 100% in utilization of intrauterine coil devices, IUCDs, may have been offered as an alternative to implant contraceptives. There was also a global shortage in condoms and birth control pills, so that may have contributed to the increase in IUCDs. For child health, nationally, there was a decline in patient visits for child health clinics for the COVID-19 period, possibly due to parents' fear of exposing their children. Similar findings were found in other LMICs like Mexico, Chile, and Haiti. And there was a 4% decline in children 3 to 6 months and a 42% decline in children 7 to 12 months. This is of concern because the vaccination schedule requires children to be vaccinated every 6 months at that stage for the MMR, etc. There was also a decline in DP3 vaccination coverage globally. As for hypertension, nationally, there was a marginal increase in the number of patients with hypertension attending curative clinics for the COVID-19 period. These results contrasted with LMICs such as Chile, Haiti, and Mexico that reported a decline in patient visits. And overall, there was an increase in uncontrolled hypertension patients. Okay, so strengths and limitations. So a strength of ours that we examined 27 months for the interrupted time series, so it gave us adequate time to judge the pre-COVID period as well as the COVID period. The interrupted time series were assessed for over-dispersion, seasonality, time, and confounding factors. However, limitation would be we use routine service statistics, and that would include like systematic data entry and reporting errors, underreporting, and missing data. However, we did perform data quality checks. Another limitation was St. Elizabeth. That parish in particular had a lot of missing data, so we couldn't include it in the analysis. And for the curative clinics, we had to use June to December due to disease definition changes. In conclusion, the impact of the COVID-19 pandemic on the healthcare utilization on type 3 health centers was significant. Various essential services experienced a decline in patient uptake and adherence. The after effects of the pandemic on service utilization may influence the morbidity and mortality of Jamaican populations for years to come. The decline in utilization of clinic services require further research. And we're finished. Oops. Do I go back up there? Do I go back up here?
All right, thank you, Ms. Michael. Our next presenter is Dr. Carol Lord. She will be online. So, Dr. Lord, can you hear us?
Yes, I am.
All right, you can go ahead and project your slides.
You're not seeing it? I'm sharing slide. I'm sharing.
Okay, we can see it now. You can go ahead.
Good afternoon, all. I want to thank the National Health Research Conference team for selecting this study, maternal and perinatal outcomes for eclampsia and preeclampsia in Stera, to be presented at this time. Oh. I want to thank my supervisor, Professor Afik McCobbins, and the other members in the specialists of the field, Dr. Reed, Dr. Grant, Dr. Michelle Harris, for assisting with this study. This is the outline of the presentation. I'm going to share some background information and the study findings. So, preeclampsia is a multisystemic, multifactorial disorder. Disease of blood pressure is greater than 140/90 on 2 occasions, taken 4 hours apart, plus proteinuria within a 300 grams within a milligrams of protein in a 24-hour urine, usually after 20 weeks of gestation in a previously normotensive mother. Eclampsia is convulsion in any woman during pregnancy or in the first 10 days postpartum, along with high blood pressure, proteinuria. But in addition to that, there is thrombocytopenia and abnormal liver enzymes. Eclampsia globally and preeclampsia is the third leading cause of maternal mortality. It accounts for 16 to 31% of perinatal deaths globally. The case fatality rate in developing countries is 14%, and preeclampsia affects 2 to 8% of all pregnancies. In Jamaica, hypertensive disorders in pregnancy is the #1 killer and accounts for 18% of maternal deaths. The complications include antepartum hemorrhage, postpartum hemorrhage, and fetal miscarriages. So, timely intervention is necessary to reduce the complications associated. These are the hospitals that we look at. They're Victoria Jubilee, Spanish Town Hospital, University Hospital. So the objective of this study, really, we aim to describe the maternal and fetal outcome in women with eclampsia and preeclampsia who delivered at these hospitals between January 2015 to December 2019. It is a retrospective cohort study at the 5 maternity hospitals, and the study population were women who were managed for eclampsia and preeclampsia. Included in the study were women admitted to the 5 hospitals during the 5-year period and their neonates, including those who were discharged. Women with known seizure disorders were excluded from the study, and those whose seizures were attributed to another cause. Previous studies estimated that the case fatality of eclampsia in developing countries to be about 14%. Assuming this figure and applying 95% confidence level and 5% margin of error, the minimum required sample size for eclampsia was 132 dockets. The sample frame was constructed for each hospital, where a list of patients with eclampsia and preeclampsia was used to select all of the eclampsia patients, 1 in 4 of preeclampsia patients, and normotensive women were conveniently selected, giving a total of 788 women for the study. Data was collected from various sources, including the electronic system with ICD-10 code, the delivery books, antenatal registers, and postnatal ward, the admission books for the female medical ward and the nursery, also the death registry. 2 trained healthcare workers using a data extraction sheet with 8 sections were used to collect maternal obstetric and delivery information and neonatal birth and discharge information. SPSS 21 and status 16 was used for data processing and analysis. Summary measures were expressed as means with standard deviation or as proportions. Cross-tabulation was performed to demonstrate the relationship between preeclampsia and eclampsia and normotensive women. Chi-square analysis was used to test the association with eclampsia and preeclampsia. Logistic regression was used to determine factors associated with these conditions. Regression model was considered for eclampsia and preeclampsia versus no hypertension. A p-value of less than 0.05 was considered to be statistically significant. Data were presented in tables, graphs, and charts. Maternal and fetal outcomes were examined. The incidence of eclampsia in Sarah between 2015 to 2019 was 2.4 per 1,000 live births. This is for a parish of residence versus parish where the care was accessed. The case fatality rate was higher among women diagnosed with preeclampsia. For the study population, the mean age was 27 years, with a minimum of 13 years and a maximum of 48 years. Most women who had eclampsia were less than 20 years, as seen in the dark blue color. And among the older age group, preeclampsia predominates, seen as the green color. Eclampsia was seen among the younger women with a median age of 22 years and interquartile range of 18 and 27. This population, they were single and unemployed. Women with eclampsia had a mean number of antenatal visits of 5.6 with a standard deviation of 2.8. This was least compared to women with preeclampsia and those who were normotensive. We are providing data here in change in weight from the first antenatal visit to the last antenatal visit. What we observed was weight gain between the first and last antenatal visit ranged from 4.6 kilograms in eclampsia to 8.7 kilograms in preeclampsia. And this was significant association. Women with hypertensive disorders in pregnancy experienced several symptoms. The prodromal symptoms for eclampsia were headache, flashing lights, and dizziness, while those for preeclampsia was mainly swelling of the hands and feet and epigastric or abdominal pain. And this association was significant for the two conditions. The significant common obstetric complications observed were postpartum hemorrhage and HELLP syndrome. Let's look at the outcome. The odds of baby dying or developing severe complications are particularly high when preeclampsia and eclampsia occur. The risk of premature birth was 22 and 19 times more likely in women with preeclampsia and eclampsia respectively compared to neonates of normotensive women. Women with eclampsia developed neonates who were 14 times more likely to be admitted to the nursery and 12 times more likely to experience fetal death. Eclampsia was seen in the less than 20 years age category in keeping with other studies. In fact, studies reported less than 17 years, suggesting the increased liability of the central nervous system response in teenage mothers. What was also interesting with this group is that they had the least weight gain throughout the pregnancy from the first to the last, in that they were not obese. This study supports similar findings of literature which report eclampsia patients were on book, and eclampsia patients here also had less than 4 antenatal visits as recommended by WHO. Headaches was the most common symptom. In fact, women would say that this was the worst headache they had in their lives for those who had eclampsia. The odds of neonates admitted to the nursery or dying was seen in this study, was in keeping with other studies. In fact, over 60% of the eclampsia women had cesarean section delivery. The research findings actually provided a good estimate for this population, but cannot be generalized. It was not a countrywide study. Some variables could not be reported in providing some information gap. In Jamaica, where maternal age at childbearing is increasing, the association of hypertension with advancing maternal age will undoubtedly contribute to a greater prevalence of eclampsia and preeclampsia and their potential adverse outcome for pregnant women and their infants. This useful information collected can contribute to filling the gaps in the maternal mortality morbidity research agenda. It will also guide practice and policies about the most frequent complication and organ dysfunction related to preeclampsia and eclampsia. Jamaica does not have an electronic inpatient name system that provides an efficient way of cross-checking patient records across hospitals by assigning a unique number for each citizen, and therefore this is limited data available within hospitals and across regions for proper reporting and epidemiologic function. This highlights the need for technological advances that can improve patient care and patient record management. Hence, there's need for a universal electronic management. We need to strengthen specialized maternal health within each tier, monitoring and consistent professional assessment. For the ICD 10 and 11 discharge coding to be taught and monitored throughout the region. It is in use, but it needs to be monitored and ensured it's being done. These are my references, and I want to thank those persons who have been assisting, including my supervisor, my program coordinators, my lecturers, the support team, the healthcare workers, and my support team, including Mrs. Alfred, Williams, my family and friends, and those who have been. Thank you very much.
All right, thank you, Dr. Lord. So you'll stay online until the next presenter does her presentation and for the discussion and question and answer. Our next presenter is Miss Selena Lewis. You can make her welcome.
Good afternoon, everyone. I am Selena Lewis, and I just want to start by thanking the Ministry of Health and Wellness for hosting this research conference and giving me this opportunity to present. I'll be presenting on the findings from my master's thesis, the association between sleep duration, hypertension, and PCOS in women from the UK Biobank, a case control study. Polycystic ovarian syndrome, also known as PCOS, is a hormonal condition that affects women of reproductive age, resulting in hormonal imbalances, irregular periods, excess estrogen levels, and cysts in the ovaries. Some cardiometabolic outcomes associated with PCOS are obesity, insulin resistance, diabetes, hypertension, and cardiovascular disease. Sleep is important for rest and recovery, cognitive function, emotional well-being, physical health, hormone regulation, brain health, heart health, longevity, pain management, and hormone regulation. Majority of the studies done have focused on sleep-disordered breathing. However, it is important to understand how sleep duration and sleep quality affects women with PCOS. In this study, we'll be focusing on sleep duration. Previous studies for women in general have found that short and long sleep duration is associated with hypertension. Short sleep duration has been found to be associated with increased blood pressure and nocturnal hypertension. The objective of this study is to investigate the association between sleep duration and polycystic ovarian syndrome, PCOS, and the association between sleep duration and hypertension among women from the United Kingdom, UK, Biobank. We conducted a case control study of women aged 40 to 70 years with and without PCOS from the UK Biobank. The UK Biobank consists of 500,000 participants. We excluded all the males, leaving us with 273,469 females. We went further to do a random one-to-one sampling of women with PCOS and without PCOS, which left us with 1,330 women after excluding the women without PCOS that were not a part of the random selection. We were left with 727 women with and without PCOS with no missing data. These are the variables that were used from the UK Biobank in this study. Hypertension, sleep duration were the dependent variables. the independent variable was PCOS status, and we used, for the confounding variables, age, ethnicity, alcohol intake, smoke status, shift work, body mass index, physical activity level, chronotype, which simply means their level of alertness, the best time throughout the day that they're alert or awake, depression, and type 2 diabetes. Sleep duration was self-reported as whole numbers and were placed in 3 categories. Short sleep was less than or equal to 6 hours, adequate 7 to 8 hours, and long greater than or equal to 9 hours. Participants were asked if they were previously diagnosed with hypertension. In the UK, hypertension is defined as a blood pressure reading of greater than or equal to 140/90 millimeters mercury based on the National Institute for Health and Care, NICE guidelines. For statistical analysis data, the standard edition 16.0 was used to conduct data analysis. Descriptive analysis were generated to characterize the study cases and controls. The association between sleep duration, hypertension, and PCOS were assessed using multivariable logistic regression models. Results. It was found that we had 420 women with PCOS in our sample and 307 women without PCOS in our sample. We found that women without PCOS were younger. The women with PCOS had a higher percentage of being of African Caribbean ethnicity. And the women with PCOS reported having a higher BMI. Women with PCOS also reported having a higher percentage of depression, higher percentage of physical inactivity, and a higher percentage reported being of evening chronotype, or level of awareness or alertness throughout the day, compared to women without PCOS. Sleep duration was not significantly different between both groups. Hypertension status was not significantly different between both groups. Sleep duration was not found to be associated with PCOS status in this study, and hypertension status was not found to be significantly associated with PCOS status. In this model, the regression model for the association between sleep duration and hypertension in women from the UK Biobank adjusted for age, BMI, ethnicity, type 2 diabetes, physical activity level, alcohol intake, and depression. When we checked for interaction with PCOS and sleep duration, no interaction was found. We found that long sleep duration was significantly associated with a 4 times higher chance of having hypertension regardless of PCOS status. Women with PCOS did not have a significantly higher risk of having hypertension compared to those without PCOS. PCOS was not associated with sleep duration. Short sleep duration was not associated with hypertension. However, long sleep duration was significantly associated with hypertension. What does this mean for Jamaica? PCOS is prevalent in the black population based on previous studies and based on my own findings from this sample size. High prevalence of hypertension is found among women with PCOS based on previous studies. However, this may not have been seen in this finding because it was predominantly a white population that was used. Jamaica is known to have a high prevalence of hypertension. Hence, more investigation needs to be done in the Jamaican population to tackle this issue. In conclusion, sleep duration was not found to be associated with PCOS. Sleep duration, specifically long sleep duration, was found to be significantly associated with hypertension independent of PCOS status. Thank you. I'd like to just say a special thank you as well to Professor Marshall Tolleril, Professor Ferguson, Dr. Bennett, Professor Anderson, Dr. Susan Chang-Lopez, and Mr. Blake for their guidance and support. Thank you very much.
Thank you, Ms. Lewis. And just another round of applause for 3 great presentations on reproductive studies. And I'll open the floor now for questions and answers from the presenters. Any questions from the online platform? Okay, not as yet. Okay, we have a question in the room. No, Dr. Edwards is after, but Ms. Tasmoyne. Dr. Crawford? Was it Dr. Crawford? Dr. Crawford and then Dr. Edwards.
Ladies before gentlemen, huh? I was just wondering why 3 health centers for the presentation on impact of COVID-19 on the health care facilities. Earlier you mentioned 3, in the beginning of your presentation you mentioned 3 health centers. I was just wondering why you singled out 3.
All right, so that's for Ms. Michael.
Oh, type 3 health centers?
Oh, it's type 3?
Yes, type 3.
Across the island?
Yes, so basically from all parishes. But St. Elizabeth had missing data, so we had to exclude it in the analysis.
Okay, thank you.
Ms. Michael again. Now, I was trying to anticipate what the results would be before the talk. I would have expected all clinics to have gone down during COVID. But I was surprised to see that the family planning clinics went up, the numbers. No, I'm married woman. I was wondering the age group of these women, was that looked into? The age group of women who were attending this clinic? Was it the teenagers? Was it the under 16s? I don't know. I'm very curious to know.
Hold on. I'm coming to the rescue.
If I may, though, to follow up on that same question, I know that one of the challenges in primary care for women accessing family planning services is the fact that a lot of them work. And I'm wondering if it was because persons weren't at work and at the time that had contributed to them being able to access the service. I was just thinking why it went up, yes.
Yeah, yes, that could be a reason, and we're also thinking about possible unemployment, so that may have pushed persons to get more family planning methods to avoid pregnancy during that financial difficult time. That's it.
All right, I see Dr. Grant has her hand up. Can she get a mic?
I think yes, I can be heard. Yes. Good afternoon again. Yes, good afternoon again. I want to, first of all, congratulate the 3 presenters on excellent presentations, each one very interesting. I would like to ask a question of Ms. Lewis. with respect to the sleep duration and the longer sleep duration and hypertension. I thought that finding was interesting and wondered what are your thoughts in terms of explaining that finding?
Can you repeat the last part of the question for me, please?
Yes, I was asking you to further explain the finding of the association of longer sleep duration with hypertension.
And hypertension?
Yes, thank you.
Okay, so previous studies have found that short sleep duration has an association with hypertension. However, there has not been a conclusive study as yet to show that long sleep duration is associated with hypertension. Some studies show an association, some studies don't. So I think further investigation just needs to be done to understand why that's the case, if there are other confounders that might be present in that association, why it can't yet be concluded.
I have a question for Dr. Lord.
Dr. Crawford, another question.
Yes.
Who is
this
it
is for Dr. Lord.
Dr. Lord is, okay, so Dr. Lord is online. Dr. Lord, no, this question is for you.
Okay. Given where Jamaica is at regarding maternal mortality and the increase that we had seen during COVID-19 and what is happening now, what programs have been put in place in order for us to even close to meeting the SDG target pertaining to maternal mortality? Over.
Thank you. Thank you for that question. Actually, there are several programs that have been in place. There's actually closer monitoring. There are guidelines that have been developed to help streamline care within the various facilities, even though that is not part of this part of the abstract that was prepared. But there are several programs, there are guidelines that are being developed, and the training has increased. There's also cases where there is plan to have education campaign. For this part of the study, this is a three-component study, and part was a qualitative assessment, what mothers feel. And what we realized is that in terms of education of mothers, that was actually on the low side. But what mothers were asking for is more testimonials being shared nationwide so that other mothers would be able to know about the life-threatening situation, for example, for eclampsia, because their posters, their flyers, their talks at the antenatal clinics, and all of these have been going on. But what these mothers were saying, let mothers who would have experienced the condition come and tell us about their experience, and we will hear it more. And so in terms of education campaign, that is one area that we're going to be exploring on a more wider scale as it relates to decreasing the maternal mortality across the nation. But we have skilled health staff at the facilities, at the health centers. We have no problem with access to care, all right? We need to improve, and as PS has indicated and the minister has indicated earlier, we have to improve the technological access, like ultrasounds, and the investigative arm of our care offered to women. So we are going to get there. I am confident of that. We have the staff that is available. We are adding staff onto the system. And so I'm optimistic about what to look forward to as it relates to decreasing our maternal mortality to less than 70 by 2030. I'm optimistic about that.
All right. Thank you, Dr. Lord. I have a question for Ms. Lewis. We note the finding that sleep duration was not associated with polycystic ovarian syndrome, is what you set out to investigate. So I was wondering what was the hypothesis behind that and what did previous studies say?
So my hypothesis was that sleep duration was associated with PCOS. Previous studies have found that women with PCOS do tend to get a shorter duration of sleep. And based on that knowledge, we know that sleep duration has an effect on hypertension. So I wanted to find out if there was some relation with the shorter duration of sleep that women with PCOS are getting with the prevalence of hypertension among women with PCOS. So I, in turn, kind of rejected my hypothesis.
Thanks, Ms. Lewis. Any questions from the online platform? Any other question in the room? All right, not hearing any. So I don't sleep too long. No, long sleep is associated with hypertension. Okay, that was a joke. So just give a round of applause for 3 wonderful presenters and presentations. And we bring this session to a close. I think we're going to have a stretch break or Jamaica Moves break.
Three, 2 more, 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right.
We have come to the close of another wonderful session, and at this time we want to thank Dr. Ardeen Harris for her excellent moderation. We thank her for taking us through this session. We also want to thank our presenters, and at this time we want to present a small token to Dr. Harris. Thanks again.
Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
3, 2 more, 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
One, 2, 3, 2 more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. After 2, make me hear you say I love me. 1, 2. I love me. 1, 2. I love me. 1, 2. I love me. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up.
Love your body, treat your body right. Love your body, treat your body right.
Good afternoon. Good afternoon. Those of us who are here in person and those of you online, welcome to our 6th session, which is entitled Social Support and Mental Health. I'll be your moderator. I'm Dr. Kevin Goldburn, Director of Mental Health Unit within the Ministry of Health and Wellness. As you can imagine, I'm very interested in these presentations that will be coming up shortly. So we have 4 presenters. And the first one is Dr. Keon Donaldson Davis, and she's coming to us from Mona Aging Center at the University of the West Indies, where she works as a lecturer since 2018. She has worked extensively in Jamaica and the British Virgin Islands in the areas of urgent care and community medicine, and she has a passion for public health, primary care, and care of older individuals. Our presenter has worked with the elderly or geriatric guru, Professor Denise Eldemire Shearer, in the development of a new geriatric training program for medical doctors, which was launched in January 2021. Our research spans the disciplines of public health and aging, with focus on the impact of COVID-19 on older persons and long-term care provision in Jamaica. As you know, that's very relevant because during COVID-19, the message that was sent out to the older persons that they must stay home. And we know it had a lot of negative impact, which I've heard Professor Eldemire Shearer repeat several times. This afternoon, she's going to present to us social support and risk for cognitive impairment among community-dwelling older persons in Jamaica. Please make her welcome.
Good afternoon, everyone. Thanks, Dr. Goldburn. All right, so today's presentation is entitled Social Support and Risk for Cognitive Impairment among Community-Dwelling Older Persons in Jamaica. Now, population aging is in effect. It is a change in the composition of the population where older persons account for an increasing share of the total population. In the Jamaican setting, population aging has come alive in that older adults account for 13.5% of the total population, which amounts to 379,000 older persons in Jamaica. The share of older persons, meaning those 60 years and over, has increased by 13.8%, while the general population has seen an increase of only 0.6% over the 2014 to 2019 period. And this is based on post-census estimates from the Statistical Institute of Jamaica. So, just a little bit about mild cognitive impairment and dementia. Mild cognitive impairment is basically an early stage of cognitive ability loss, including memory, language, as well as visuospatial perception losses. But these individuals are able to maintain the ability to independently perform most of the instrumental activities of daily living. Dementia is an umbrella term for a number of neurological conditions, of which the major symptom is the decline in brain function due to physical changes in the brain. So, Alzheimer's disease as well as vascular dementia are examples of dementias. Now, in terms of the burden of mild cognitive impairment and dementia, approximately 10 to 20% of persons who are 65 years and over with mild cognitive impairment develop dementia over a 1-year period. This is information out of the United States from the National Institute on Aging in 2021. In terms of the global burden, the prevalence of MCI stands at about 19.7%. The prevalence of dementia ranges between 5 and 7% in the 60-year and older age category, which amounts to a whopping 57.4 million people living with dementia worldwide. In Latin America and the Caribbean, mild cognitive impairment, the prevalence of mild cognitive impairment ranges between 6.8 and 25.5, and dementia prevalence stands at about 10.66, which is notably higher than the global prevalence. In Jamaica, studies done by Eldemar et al. In 2018 showed that the prevalence of dementia stands at 5.9%, which is comparable to international or global prevalence data. Now, the thing with dementia is that its diagnosis begins with screening, and there are several screening tools that are widely used to assess both mild cognitive impairment and for dementia. And for the purposes of this presentation, we'll be looking at the mini-mental status exam. Now, in 2012, there was a health and social survey done of the older persons in Jamaica, and this paper is an analysis from data from that 2012 study. In the method, I will provide some general information on the methodological approach and used in that study, and for the remainder of the talk, I'll walk you through the data analysis done for the purposes of this paper. So the objectives of that study is that it were to assess the health and social status of older persons in Jamaica, as well as to identify the needs of the older adult population. Now, with respect to the method, in 2011, there was a sample of 2,943 older persons that were drawn from the southeastern parishes of Kingston and St. Andrew, St. Catherine, and St. Thomas. Now, for recruitment, we utilized a 2-stage cluster sampling method. The first cluster units were chosen from enumeration districts across those 4 parishes with I'm sorry. They've started the wrong version of the presentation, and so the slides are not what I'm expecting, so my apologies. So the first cluster units were enumeration districts across the 4 parishes with the probability of selection of each enumeration district proportional to its size. The second stage of random selection were households, where one household represented one individual. So there were 35 clusters chosen from the enumeration districts and then 85 individuals per cluster, which amounted to the 2,943 participants. In terms of the data collection tool, a questionnaire was used, and it explored some major domains which included demographic and socioeconomic factors. And there were some standard instruments as well that were used, including the mini-mental status exam. So the objectives of this paper were to describe the social support among older Jamaicans by mini-mental status exam scores, as well as to identify relationships between social support variables and mini-mental status exam scores. Now, MMSE scores were available for 2,782 participants, and there were some key variables that were explored that were considered social support indicators. So the variables were number of children alive, caregiver presence, quality of relationship with children, source of main physical support, as well as source of main emotional support. So those were the indicators. In terms of our data analysis, we use version 20 to analyze the data. Confidence intervals were generated with a level of significance of 0.05. Mini-mental status scores were dichotomized and scores less than 20, dichotomized to scores less than 20 and those of 20 and above. For the purposes of this study, the mini-mental status scores between 0 to 19 were designated lower scores. A logistic regression model was created which incorporated age, sex, highest education level, as well as the social support indicators that were listed on the previous slide. In terms of the results, mini-mental status scores range between 0 to 30. The median score was 20 with an IQR of 7. Now, there's a table that I prepared for you which showed the socio-demographics, the support indicators, as well as the mini-mental status exam scores. Now, the significant findings were that females were more likely to have lower scores than their male counterparts. The median age for persons in the lower score category was higher at 76 years than those, and it was higher than those in the higher score category where the median age was 71 years. And of note, there were no differences noted regarding the number of children alive by score category. A few other important findings were noted. So those among the persons whose scores were considered lower, 8.9, so close to 10% of those individuals rated the quality of their relationship with their children as poor or non-existent. And the majority of persons in the lower score category also considered their main source of physical support to be themselves. The plurality of individuals who were in the lower score category also considered themselves their main emotional support. Other findings included the fact that 73% of persons with lower scores had no caregiver. 1/10 of persons with lower MMSE scores had no children, and it further lends credence to the fact that, or supports the fact that 8.9% of persons with a low scores, 8.9% of persons among those who had low scores rated their relationships with their children as poor or non-existent. So Poor quality relationships with children were more likely among those lower MMSE score category. Persons with caregivers were more likely to be in that lower score category as well. And older age, as well as a primary level education and below, were associated with lower MMSE scores. Just a few points to discuss. Only a few studies were out there that looked at social support needs of persons with cognitive impairments, and those studies were predominantly found in the North American as well as Asian spaces, so like in China, for example. But there was limited data on this type of assessment found for the Caribbean countries, Jamaica included. Our results are very similar to prior studies that were done, which showed that persons with milder dementia generally reported lower perceived social support. Our paper had a few limitations. One, first of all, the perception of social support may be impacted by cognitive function, as alluded to in previous studies. Social support indicators are more numerous than those captured by this study, so therefore a generalization is not possible. Social support indicators, when applied in the context of MMSE scores, may not accurately capture the need for social support, okay, especially since a low MMSE score does not by itself speak to the functionality of individuals. So, in conclusion, lower MMSE scores are known to be associated with an increased risk of cognitive impairment. Many community-dwelling older persons at risk for mild cognitive impairment actually lack the adequate social support that they need. Persons with lower MMSE scores should receive close clinical surveillance once identified through screening, and be prioritized for community-based social support interventions. Programs incentivizing caregiving can benefit those who have mild cognitive impairment or dementia. Excuse me. Further exploration of the nexus between cognitive impairment, social support, and level of functionality in the Jamaican setting is warranted. Thank you. Sorry.
Thank you very much, Dr. Donaldson Davis. Sorry you weren't able to show your slides, but I think we still got the message from what you were saying about social support and the elderly. So I will go to the next presenter, and then after the next presenter, we have some questions before we go to the last two presentations. So our next presenter actually presented before. Her name is Ms. Selena Lewis. She's an epidemiologist and research assistant in the Epidemiology Research Unit of the Caribbean Institute for Health Research. And she's currently assigned to the Caribbean and South America team-based strategy to control hypertension, otherwise called CATCH study. Ms. Lewis holds a bachelor degree in basic medical sciences with specialization in anatomy, first-class honors, and a master in science in epidemiology. In 2021, she received the National Scholarship for Mathematics Science for postgraduates in honor of the Honorable Dr. Mavis Gilmore Peterson, a former Minister of Health. And her primary aim, as you heard in the presentation before, is on PCOS, and she will now be presenting to us on the influence of health systems and patients' experiences on self-reported medication adherence in Jamaica and Colombian patients with hypertension. It's a cross-sectional, cross-country comparative study. Please make her welcome.
Good afternoon. I'll be presenting the findings on the self-reported medication adherence in Jamaican and Colombian patients with hypertension, a cross-sectional, cross-country comparative study on behalf of Professor Marshall Tullereed. Non-adherence to hypertensive medications can result in uncontrolled high blood pressure, suboptimal clinical outcomes, and avoidable healthcare expenses. Factors contributing to non-adherence are multifaceted and can be classified as patient factors, provider factors, health systems, facility factors, and community factors. In this study, we'll be focusing on health systems. The World Health Organization, WHO, defines health system as a group of connected, interdependent parts, individuals, organizations, and actions whose major objective is to preserve, restore, or improve health. Jamaica and Colombia has differing population sizes. Jamaica has a smaller population size. This data was taken from PAHO. Jamaica is predominantly black. Jamaica has a shorter life expectancy. Jamaica has a lower literacy rate and a lower public health expenditure, GDP, compared to Colombia's population. Jamaica and Colombia's health systems are different. Jamaica's public health system is primarily through government-run and sponsored clinics and health facilities using paper records and is free of charge at point of service, while Colombia's public health system is through practitioner offices and facilities contracted by government through insurance companies to provide care to patients using an electronic medical record system through a public health insurance plan, meaning everybody in Colombia has a health card. The objective of this study is to examine whether differences in the Jamaican and Colombian health systems influence self-reported medication adherence among hypertensive patients, independent of patient characteristics and healthcare experiences in each setting. The CATCH study, known as the Caribbean and South America Team-Based Strategy to Control Hypertension, is a National Institute of Health NIH-sponsored study to improve hypertension in the Caribbean and South America. It is a 6-year study with 3 phases. The planning phase, which lasted for 2 years, the implementation phase, which we are currently in, which will last for 2 years, and the scale-up phase. We will be using the data being presented will be taken from the planning phase of the study from the needs assessment questionnaire. The study was conducted in primary care clinics in both countries in 2021. Colombian patients were selected from an electronic medical record system, while Jamaican patients were identified from clinic attendees on hypertension treatment days from randomly selected primary care clinics. All interviews were conducted by telephone in both countries. From the needs assessment questionnaire, we extracted the following variables: sociodemographic, hypertension knowledge, patients' healthcare experiences, and medication adherence. Medication adherence was measured using the Impact Mass Medication Adherence Scale using 2 questions. The first question, over the last 7 days, on how many days did you not take any blood pressure pills? And the second question, over the last 7 days, on how many days did you cut back or not take the full dose of your blood pressure pills? The responses from the participants were totaled, and if they got a score of 6, they were considered to be high adherent. A score of 5 or 5.5, they were considered medium adherent, and less than 5, they were considered to be low adherent. From our sample, we had 288 patients in Jamaica, 288 patients in Colombia. We found that our Jamaican population were younger. Our population sample were younger. Our Jamaican patients reported less percentage of Jamaican patients reported having a more than high school education compared to Colombia, and a lower percentage of Jamaican patients reported being in a married or common law relationship compared to Colombia. These results were significant. There was no significant difference in sex and hypertension knowledge. There was a lower percentage of Jamaican patients that reported doctor discussing blood pressure treatment plans compared to those in Colombia, and a higher percentage of Jamaican patients reported pharmacists discussing substitution of medication compared to those in Colombia. Doctor discussing medication changes was not significantly different in both countries. Medication adherence was significantly different between countries, Jamaica in blue and Colombia in orange. Colombia had a higher percentage of patients reporting high adherence compared to those in Jamaica, and Jamaican patients reported a higher percentage of medium and low adherence. When we did our regression model, unadjusted, we found that Jamaican patients had reported as 7.3 times more likely to report low, medium medication adherence compared to those in Colombia. When we went further to adjust that model for age, sex, education, urban rural status, and hypertension knowledge, the odds ratio changed to 7. When we adjusted for doctor discussing treatment plan and doctor discussing medication changes, the odds ratio changed to 6.6 but remains significant. When adjusted once more for pharmacists discussing medication substitution, the odds ratio changed to 6. However, it remains significant. In conclusion, patients within Jamaica's health system were more likely to report low, medium medication adherence compared to patients within Colombia's health system. Differences in patients' healthcare experiences did not significantly impact the influence of the health systems on self-reported medication adherence. The CATCH study allows us to do further investigation to understand factors in the health systems that influence patients' medication adherence. Thank you. Special thanks to the Minister of Health for hosting this conference, and Professor Marshall Tollereid for giving me this opportunity, Professor Ferguson, Dr. Susan Chang-Lopez, Dr. Bennett, Mr. Blake. Thank you for your guidance and support.
Thank you, Ms. Lewis, for a very important presentation, because as we know, adherence, especially non-communicable disease, one of the biggest issues to how to improve adherence. So at this point in time, I want to see if there are any questions online. Are there any questions online? Okay, there are no questions online. Are there any questions in the room? I'm sure there are questions in the room for the two presenters who have presented so far. Please go ahead.
Hi, good afternoon. I have a question for Dr. Donaldson. Reflecting on your study, you had mentioned the impacts of lower social support for patients who are living in the community setting. Now, when you consider patients living in institutionalized settings in the government sector, what recommendations would you make to improve their outcomes, considering that they have less social support traditionally?
Recommendations. Well, the recommendations would be basically uniform for the group of persons who are considered vulnerable, which is to identify the areas of need, whether the social support pertains to family support, or it pertains to physical support, financial support, whatever the aspects that we have identified as areas of needs or gaps, then these are areas that need to be addressed using various platforms, may include various approaches to resolution, or to, the recommendations would be wide and varied because of how comprehensive social support is as an indicator, right? There are several points or aspects that you could explore. In fact, there are some standardized tools and validated instruments that are available that can assess social support on various levels. So whatever the needs are that are identified, whether the person is within the community setting, within the home setting, within the institutional setting, then it is just for us to identify them and address them as best as we can. Right. But expect them, especially among those people who have cognitive impairment.
Right, so in terms, well, what you describe is basically strengthening the social support, well, yes. But when it comes on to persons with memory impairments, yes, would you advise implementing memory assistance programs, whether it be through the public health clinics? Because that may also be a significant factor in poor social support, is that family members don't know how to exactly help people with lesser cognitive function as they age. Would that be feasible?
Absolutely, absolutely feasible, but any sort of intervention that is required begins with identifying these vulnerable groups, so checking for them and monitoring them and seeing what their needs are, and then addressing them. As you said, this is one way in which the needs can be addressed, but the first step is really identifying the individuals and monitoring them to see what it is that they need, because memory aids and memory support and so on is just a very small aspect, an important aspect, albeit, but a small aspect of the level of care, the level of the types of interventions that are required for this group. So yes, to the answer to your question, for sure.
Thanks much, Doc.
You're welcome. Yes, of course.
So thank you, Doctor, for your presentation. And I'm glad to hear that a mention was made. I just want to give you a chance. That the children are an important factor, and the number of, and how they relate to the parents are important in terms of decreasing the impact of dementia. But did you explore other support from other community organizations like churches and other organizations? Did that play a factor in the outcome?
All right. So to answer the question, strictly speaking, no. So the answer is no. But on the basis that the original aim of this study was never to elucidate social support, we secondarily looked at this because we see that this area, the body of information surrounding social support for persons who are cognitively impaired is limited, right? But when saying so, social support can extend from beyond this family setting into what exists within the community setting, friends and external circles and so on. So it is for further studies to explore what exists out there. We know that the church and other faith-based organizations play a pivotal role in providing a social circle for older persons especially. So I have no doubt in my mind that there would be a significant contribution from that aspect. But it hasn't been documented, but it certainly is something to look at.
All right. Thank you, Doctor, for your presentation. I was listening carefully. I would have been glad to have some visual while the presentation was going on. So I have to be scribbling some notes. So what are some of the indicators that you used in your studies? Did I hear well number of children who are alive?
Yes.
Okay. And then I see something about 0 to 19 were lower score. That was said? Okay. And female had lower score. All right?
Mm-hmm.
So I was wondering, and then there was this point I jotted down. Said they had their relationship with their children were poor. How could that be? No. I've been here 23 years. I'm not just coming. The thought line shouldn't be that the relationship of the mother with their children is poor. But this is what you are finding in the study. Am I correct? Because I took note, I'm sure. I want to be sure.
We are saying that 8.9%
yes,
of persons
I know that
who had a low score rated their relationship. So it is the minority of persons.
Yes.
But we're saying that because it is a vulnerable group, as small as the percentage point is, it is still significant because there is still a gap that exists among these vulnerable individuals. You can't take it for granted, in other words, that, once children are on board, yes, persons may have four children on average, but that this relationship is going to be solid and that there is going to be a cushion for them in terms of care.
Okay, so that was why I put that. That's why I wanted to get clarity on that.
Thank
because the greater majority is the opposite of what this is.
Sorry,
no.
I didn't hear this last point.
I said the greater majority
yes.
would have been the opposite of this 8.9.
Absolutely.
Okay.
Absolutely.
Then I had this point here, sorry. Persons with care were in that age as well. What do you mean, persons with care?
Persons
who
with
got care, people were attended to.
Right.
Were also in the age group that had low score.
So we're saying that 78% of persons with low scores had indicated that they had no caregiver. Now, whether or not they absolutely needed a caregiver functionally is outside of the scope of what we examine. But again, it's just a conversation starter to the fact that here we have a vulnerable group of persons who may have an impairment in their ability to think. And they are saying, the majority is saying that they have no caregiver on board, right? And to me, it's certainly worth more exploring. What's happening here? Is it that the majority do not need a caregiver? That may very well be so. But it is still for us to pay some attention to the fact that this group of persons may need help and we're overlooking them.
Yes, thank you. I have it. Thank you.
You are welcome.
Thank you. Then I have a next question for Louis. Can we ask Louis?
I have a question for the lady who just sat down.
Yes.
Yes. Social support within the context of your research,
yes.
Did it take into consideration social protection any at all?
Social protection.
Okay.
We simply looked at the indicators that I had listed on my slide that we didn't see. But it just explored those variables that were accessible to us from this data that we were able to secondarily look at. So unfortunately, we didn't go into the realm of social
protection.
Social protection.
Well, it could be considered as a way
Absolutely.
forward for program policy
yes.
objectives for your social support
yes,
program.
and that is one of the domains that is explored in some of those validated tools that exist that look at social support as well. Thank you very much for your question.
Okay. Miss Lewis, thank you for your presentation. Yesterday I was in the room and somebody presented something about Colombia. And then I asked a question, what is happening between Colombia and Jamaica? And I hear the young person telling me that the health system were different. But your research is telling me there was no difference between the health system. Did I hear that? I just heard that.
So my study shows that there is no difference that there is a difference with medication adherence between both health systems. When we adjusted for patient experiences, we found that those did not contribute to that difference. So I'm not sure if I...
Okay, that's all right.
okay.
That's
okay.
Calm down, no problem. We just want to have a discussion. So you realize that in Colombia, everybody have health card.
Right.
But in Jamaica, we all don't have. So it depends on your ability and capability to buy yourself one or get one or be in a space where you can afford. So wouldn't that have made some difference in the adherence to the medication? Because here we talk, when we go to the pharmacy, can you give me the cheaper one? Which one? If this one, doctor, I prescribe. So is that a good thing by your, no, listen now, just you and me. Is that a good thing?
Okay. So further studies need to be done to understand why is it that there is that difference with the medication adherence within both health systems. If it is a case wherein when we do those further studies we find that it is the health system itself that is the issue, then changes would have to be done to implement a new form.
What if money is the difference?
What is the difference?
They don't have money.
Is money the difference?
Yes, they have to purchase the medication. It's not free.
Well, if money is the difference.
Someone pays for it. Okay, even if it's free, someone pays for it. No, so. All right, so thank you.
Okay.
This I must wrap up. Thank you.
All right, thank you for
good
the
presentation.
Thank you.
Yes, thank you, Ms. Lewis and Dr. Davis. And I also think that in difference between the two groups, between Jamaica and Colombia, I think it has to do with the fact that in Jamaica is a public system, whereas in Colombia is a private system. I think we need to look at the interaction, because in America we get a therapeutic alliance in the private system as opposed to the public system. And that's just from my psychiatric perspective. Okay, our next presenter is Ms. Shanae Linton, hope I pronounced her name correctly. She's a highly skilled registered nurse with a passion for healthcare and a commitment to improving the well-being of others. She's driven by a passion for addressing broader public health issues, and she is currently pursuing her Master of Public Health with an emphasis on health management. Through this program, she aims to enhance her knowledge of healthcare administration and management. Also of her professional life, she is a devoted mother and wife. Please make her welcome as she do her presentation. Patient satisfaction and factors influencing satisfaction in accident and emergency departments of Type A hospitals in Jamaica. Patrice is here. So before she presents, Patrice. Patrice to go first. So before you present Ms. Linton, we're going to ask Patrice, who is online, to present. So Ms. Patrice White-on-Simit, she's a clinical psychologist in training. She's currently pursuing a PhD at Curtin University in Australia. She's an advocate for mental health. She's a wife and a mother. And I know her quite well. She is very passionate about mental health issues. I'm a big advocate for mental health issues. And so she's going to present to us a paradigm shift in mental health, stakeholder perspectives on improving healthcare access for people with serious mental illness and chronic physical illnesses. Please make Mrs. White-on-Simit welcome.
Hello, good afternoon, everyone. Are you able to hear me? I just want to make sure. Yes, wonderful. Thank you. I'm hoping you are able to view my slides. It is 4:30 a.m. in Australia, so sorry if I sound a little bit groggy. All right, today I will be talking to you about our study on a paradigm shift in mental health, the stakeholders' perspectives on how to improve healthcare access for people with serious mental illness and chronic physical illness. Now, firstly, I want to point out that this is actually a study that was done in collaboration between Curtin University and the University of the West Indies. So I want to recognize my Curtin-based team as well as Professor Abel, O'Shea, Dr. Lalwani, and so on from the University of the West Indies. And I'd like to thank those who...
Patrice?
Yes?
Yes,
are you here?
We're not seeing your slides. We're not seeing your slides.
Oh, I asked if I
We are
should
seeing you
share
very
them.
well, but
Okay,
not your
sorry.
slides.
All right, let's
Share
go.
slides.
Are you
Go ahead.
seeing it now?
It's coming up. It's coming. Yes, we are seeing it now. Computer slide
Oh,
share.
thank you so
Thank you.
much. Sorry about that. All right, let me make sure I made them big.
Can you put on slideshow for us, please?
That's what I'm doing. Okay, there we go. Good. Right. So I just wanted to acknowledge the team. All right. So just for some background, people with serious mental illnesses relate to those who have schizophrenia and other psychotic disorders, bipolar disorder, and moderate to severe major depression. And research done globally has shown that these people have a higher rate of mortality and a significantly shorter life expectancy of 15 to 30 years than people in the general population. Now, this is a huge difference in terms of the years lived. This has been found to mostly be due to the high rate of chronic physical illnesses among people in this population. And this tends to be mainly non-communicable diseases such as cardiovascular diseases, diabetes, and cancer. Within this population, cardiovascular disease is up to 12 times more common. Diabetes about 3 times more common. Within low and middle income settings, it is estimated that between 10 to 68% of people with serious mental illnesses also have chronic physical illnesses. Now, one of the number one barriers or challenges why they feel like people in this population are more prone to physical illnesses is the challenges that they face when they're trying to access health care. And it's so serious that chronic physical illnesses account for 70% of the mortality rate among this population. Now, why is access to care such a big issue? The access to care based on this study is defined as the ability to identify healthcare needs, to seek help, to reach it, and to obtain it. Now, the concept that was used in this study to assess healthcare access is based on Levesque, who identified 10 dimensions of healthcare access. There are things on the service arm that looks at how accessible the health system service is itself. And then there are individual factors that actually determine if people access care. And as you see in this diagram, they're parallel. So healthcare needs to be approachable, and the person also needs to be able to perceive that they have a healthcare need. It has to be acceptable, meaning that within the cultural setting, the norms and the values of the culture allow you to be able to go to the health center without any problems. And you must have that capacity to seek care. Health services must be available and able to accommodate you, and people should be able to reach. It needs to be affordable, and people have to be able to pay. And it has to be appropriate. Now, this level of access speaks to quality of care. People have argued, how does quality of care connect? It does, because if I have a healthcare need, I approach a health service, but my healthcare need is not addressed, I really haven't accessed healthcare. So these are the dimensions when I'm talking about healthcare that I'm actually looking at in this research project. Now, just to give some Jamaican-based background, we know that non-communicable diseases are the leading cause of death in Jamaica. And although there have been efforts to integrate mental health care into primary care, research over quite a number of years has shown that primary care physicians do not regularly screen for mental illnesses, and that the mental health services don't provide a comprehensive management of physical and mental illnesses. So far, there's been a lack of research that looks at healthcare access for this specific population who are highly vulnerable. Now, this study that I'm presenting is a part of our broader mixed method study that's looking at the overall enablers and barriers to healthcare access for this population. But specific for this presentation is I'm going to be focusing on what are the recommendations that were given for how the healthcare system response can be improved. Now, this part of that I'll be presenting on is a qualitative study. So we used a constructivist grounded theory approach to be able to develop a localized theory about enablers and barriers, as well as approaches that need to be taken for improvement of the health system response. It consisted of 57 participants across 6 participant groups, and they were recruited in various manners. We involved health policymakers, primary care physicians, psychiatrists, mental health officers, people with severe and enduring mental illnesses, and their caregivers. So as you notice, the participant group is very broad, and this is because we wanted to have a comprehensive view of the issue of people at different levels of the system being able to pinpoint what exactly are some of the advantages of the system, what are the disadvantages, and how do we address these issues. We especially wanted to focus on the people with serious mental illnesses. As you notice, they have the largest participant group in the study. And that's because often their voices are not included in things that are about them or as a source of information, relevant knowledge that can actually help develop systems. And the WHO has asked us to do more to include this group in research as experts of their own health. Now, sorry, I think I went ahead too fast. Now, this will be our focus slide for now. So just to give you some context, this is what we found coming out of the study, but just to give you some context, these are the strategies that the participants felt were needed to improve the health system response. But for you to understand this, I'll tell you the background. So we found that across all participants groups, they recognized that the free public health system was the #1 enabler of healthcare access. People were very grateful and recognized that based on the socioeconomic status of most people who have severe mental illnesses, the ability to go to a community-based health center that has co-located services was a huge advantage for them to get any level of care. So they were very thankful and recognized this as a valuable part of the public health system structure. However, despite this strength, they noticed several barriers and gaps that existed within the health system that limited their ability to access care. One of the main things was stigma and discrimination. And they recognized that stigma and discrimination existed at all levels of the society and even within the health system response to them. They also noted gaps in policy and guidelines, and we're going to talk about each of them in relation to this diagram. So the #1 thing that was needed based on stakeholder feedback is a paradigm shift in mental health. And this paradigm shift means recognizing that mental health needs to be addressed from a holistic standpoint and using that approach to care to improve the outcomes for people with serious mental illnesses, again, who are more prone to develop other non-communicable diseases. So some of the key recommendations made was, 1, to make mental health sector priority. Now, let me be clear, this data was collected in 2020, so we are going to talk about what has been done since then. Secondly, reducing stigma and discrimination. Now, as I said, they said stigma and discrimination exists throughout the health service. They recognize that this is particularly potent within hospital settings where there are a number of barriers for people with mental illnesses to get care. They said that once they present, sometimes the administrative staff, sometimes the security guards act as gatekeepers and prohibit them from being able to see the doctor. They're recommended to mental health services when they're coming for a physical health concern. And they will not present because sometimes they're embarrassed or made to feel ashamed. And people loudly declare that they are mentally ill. And so that keeps them away from accessing healthcare. So some of the key recommendations for this was One, there needs to be improved training of health system staff. And yes, this extends to physicians and clinicians, but even extending to administrative staff and security personnel, because again, they act as gatekeepers. Another one was to increase mental health promotional messages. So as stigma and discrimination is widespread in the society, there's a need for greater emphasis on promoting mental health, especially as this may help to address some of the social support gaps for these people, which was found to be very great in this study, that they don't have much social support. The next one was about filling gaps in policies and practices. So one of the things that came up, especially among the clinician groups, was that it was unclear whose responsibility physical health really was for people with mental illnesses. So, for example, most psychiatrists didn't see physical health as a part of something they're responsible for, even though they recognize that international best practices require that they screen for physical health conditions. Numerous barriers were noted as causing this gap, but they said there was a lack of a clear policy guideline for this population about what are the co-management requirements between a primary care physician and a psychiatrist to manage the holistic care of these patients. Another key area was about improving health system infrastructure. Mainly participants focused on the lack of a computerized system, issues with the facilities being inadequate to properly conduct screening within the community health system service. They talked about sometimes mental health not having a designated room, not having enough space to facilitate patients, which made it hard to conduct any sort of physical health monitoring. Another issue, of course, was related to workforce problems. Of course, we know that there's a limited number of specialized people with mental health credentials, and that was seen as a problem. But several solutions were suggested. One is that task shifting and sharing, where we redefine the roles and responsibilities of different members of the team. It was suggested that community health aides can do more, finding creative strategies to make sure that more can be done to help meet some of the needs of this patient population. There's also about encouraging psychiatric study. Some of the psychiatrists noted that even studying psychiatry was a stigmatized area because psychiatry was not recognized as a legitimate segment of medical professional, not as recognized or prestigious as other areas of study. And so there needed to be more incentives to encourage doctors to want to pursue psychiatry and to recognize it as something valuable to our society. And the third thing, this came up across all groups, was the need to invest in multidisciplinary teams. All groups recognize that the current health system response to mental health, especially as it relates to people with serious mental illness and chronic illness, was limited because of the biomedical approach that focused heavily on prescription medication. The number one barrier to people with mental illnesses accessing care was poverty. As that lady pointed out earlier, sorry, I didn't catch your name, medication adherence is affected because they can't afford it. They can't afford medication. They can't afford food. Some of them have unstable housing. The people with mental illnesses are an especially vulnerable group because they're so marginalized and stigmatized. And so when we talk about respond to social need, actually investing in multidisciplinary teams is a part of that. More social workers, more psychologists, more occupational therapists, people who can address not just the medication part of it, but who can tap into skills training and development to help improve the quality of their life so they can better manage their health. And so that leads to the part about respond to social needs. So the major gap recognized in the system, again, across all groups, was the lack of focus on social factors as a key contributor to the challenges that people in this population face. And that as a health system, there's a need to give greater focus on how do we respond to social need within the health service. So some persons suggested that a multidisciplinary team approach, multi-sectorial approach was needed, and I'll talk about that a little bit more. So these were the key things that came out in the study. Now, what are some of the key points that we need to talk about? So since the time of this study, we know that some actions have been taken. The primary healthcare reform for Jamaica report that was recently released indicates that mental health has now become a priority issue. I noticed that COVID-19 must have contributed to that in some way. We saw recently that the Medical Council of Jamaica has announced a mandatory training for primary care physicians to upskill, which is greatly needed and a move in the right direction. And greater sensitization has been happening about mental health in the public sphere. So these are advances that the systems has made. Now, what are some of the things that are needed further? Further actions that need to be taken based on the recommendation is moving mental health from just being related to a health issue to one of a social issue. Now, Hutchinson 2009 already outlined a great deal why it's important that non-communicable diseases are seen as a multi-sectorial issue, because it's necessary for economic viability that it's addressed as a civic issue. So people will stop seeing it as their problem issue and recognize that it's something of national interest, that we need to focus on NCDs more and get different sections of the society involved in that response. There's also greater need for shifting from the biomedical approach. In the World Health Report 2022, the WHO has put forward the need for person-centered, human rights-based, recovery-oriented approaches. Now, recovery-oriented approaches focus on teaching people with mental illnesses, upskilling them to be able to do more self-management, equipping and empowering them with the skills needed so that they can better manage their lives. It's not so much about medicating, but it's now about empowerment. And so taking steps towards figuring out how can we pilot and consider this within our local context. Again, invest.
Can you wrap up, please?
Invest in. Time is up?
Yes, you need to wrap up. Yes.
Yeah, I'm coming. This is the last slide. And investing in multidisciplinary teams and in implementing structured piloting of task shifting and sharing, and of course, improving training within the health system staff. Sorry about the time. Thank you very much.
Thank you, Dr. White-Smith. Of course, her presentation is very dear to me. It's up my street. So, I could sit here a whole evening and listen to her. But to be fair to you, we must move on. So we're going to ask Nurse Shanae Linton to do her presentation. Please make her welcome.
Thank you. Good afternoon, everyone. I'll be presenting this afternoon on patient satisfaction and the factors influencing satisfaction in the accident and emergency departments of Type A hospitals in Jamaica. So just some background. The Institute of Medicine defines quality care as the degree to which health service for individuals and populations increase the likelihood for desired health outcomes and are consistent with current professional knowledge. It also encompasses how care meets the needs or exceeds the needs of patients and their expectations. And there are the Agency of Healthcare Research and Quality put forward some domains that are used to measure quality in healthcare. One such is non-maleficence, which is do no harm, patient-centered focus, and customer service, evidence-based treatment, timely care, and equity in how services provided. So we want to establish that patient satisfaction is an important aspect and a very strong indicator of how quality service is delivered. And we use patient satisfaction to refer to how patients evaluate the quality of care that they receive. Patient satisfaction offers information on the provider's success at meeting the expectations that are most important to the client, and it is the key determinant of whether or not these patients will continue to have good and positive future health-seeking behaviors. When we looked at studies done previously, we highlighted that there are some. Bursch et al. In 1993 determined that what matters most when considering emergency room patient satisfaction is the relevance of how care was delivered. And they concluded that while time was significant, the most crucial factor was how patients felt that they were tended to. They highlighted factors such as thoughtfulness of their providers, the knowledge base and the caring attitudes of staff, and whether or not their complaints were handled with urgency. Roberts in 2001 found that other factors affected satisfaction, such as gender, place of living, educational level, age, income, marital status, and so on. The studies in Jamaica that have been done to measure patient satisfaction so far have primarily been centered around nursing care. And Buchanan et al. In 2015 explored patient satisfaction in nursing care in emergency departments of an urban teaching hospital and found that the mean satisfaction score was 32.6 out of a possible 42. So, why study patient satisfaction? This satisfaction amongst our citizens is always in the media, and it is said to deter citizens from readily seeking health care services within our institutions. Members of society continue to express their opinions of poor quality services that are being offered and the substandard customer service that is being offered in our public institutions. And we found that there was no study found in Jamaica to actually focus on the overall experience in the emergency rooms in Jamaica. So we set out to examine the factors that influence patient satisfaction, and we believe that this will be most helpful in how we go forward in treating our patients. Described the aim before. Our objectives were to look if there were any correlation between socio-demographic characteristics and patient satisfaction, to determine how patients perceived the wait time that they had to receive service. Also, we looked at patient satisfaction in terms of the information they received, the responsiveness of personnel to their needs, the empathy shown to them. So our methods. We embarked on a cross-sectional study, and we used a quantitative approach to collect data using questionnaires. The population was all patients seeking medical care within the accident and emergency departments of Type A hospitals in Jamaica. And we know that the Type A hospitals are Kingston Public Hospital, Cornwall Regional, and the University Hospital of the West Indies. The persons that were included were persons that were of age 18 years and older, and who could provide informed consent. Who were excluded, persons that were of ESI 1 or 2, that means that they were determined as unstable or emergent, or their situation was emergent or needing urgent care. Persons that were unable to provide informed consent, visitors and not patients were excluded, and persons that were of impaired cognitive status. We also excluded persons that were admitted to the hospital, meaning that even though they went through A&E, after being seen and treated, they were admitted. Those persons were also excluded from the study, as the tool that we were using was specific for emergency department visits, as having been seen and discharged from the A&E department. So using information based on the amount of persons that were seen in the emergency rooms for the type A hospitals, we came upon and we determined the sample size, which gave us approximately 267 patients, the majority being from Kingston Public Hospital, 92 from Cornwall Regional, and 60 from University Hospital of the West Indies. We chose days at random to visit the hospitals, and weekdays and weekends were included. Patients were approached randomly and at various stages during their visit, and those who were refused, another patient was selected. During recruitment, informed consent was obtained. We used a 38-item questionnaire, interviewer-administered questionnaire, to collect our data, and the questionnaire consisted of questions regarding socio-demographic characteristics, wait times, patient satisfaction with information received from healthcare personnel, responsiveness of personnel to their needs, the empathy shown, and the care provided. We used SPSS version 20 to analyze the data, and we used descriptive as well as inferential statistics to determine the values or to analyze what was the data. A significance level of 0.05% was used, and the EDCAMS questionnaire was broken down into composites that we would use to measure or determine patient satisfaction. I'll break down the composites later. The results from our study: the majority of patients that participated were female, 55%. The mean age of the respondents was 43.52 years, and the age distribution revealed that 24% were belonging to the 18 to 28 age group, and 19.9% belonged to the 29 to 38 age group, as well as the 49 to 58 age group. The educational level that was most prevalent was secondary education, with 66.7 persons reporting that they were from that level of education. 69.1 were employed, 30.9 were unemployed, and 35% disclosed that their income ranged between $15,000 to $19,000 weekly. And we have a breakdown of the socio-demographic characteristics. With regard to the composites that the questionnaire had broken down the measurement into, we saw where the mean score for these composites range from between the 60s and the 70s. These scores were average out of 100. So getting timely care, which measure the initial patient interaction from they arrived at the emergency department to when they received care within 30 minutes of their arrival. The mean score was 66 out of 100. Communication with doctors encompassing courtesy, respect, along with effective communication, the mean score was 76. Medication-related communication was 63. And communication about follow-up care was 63 as well. Majority of patients, 52.1%, reported that they waited from registration to completion of care over 6 hours. This was followed by 22% stating that they 22% stating that they waited 46 hours to receive care, and the lowest number of responded, 6%, stating that they spent less than 1 hour in the emergency department. 54.7% were satisfied with the time that they spent, even though it was over 6 hours, and 45.3% stated that they were not satisfied with the amount of time they spent. We noted that there was a direct association between the hospitals and the amount of time spent. The majority of patients' responses from Cornwall Regional Hospital stated that 88% of them waited more than 6 hours. At University Hospital, it was also greater than 6 hours. And at KPH, 33.9 stated that their wait time was between 4 to 6 hours. The doctors and nurses' communication, majority of patients reported that they were treated with courtesy and respect by the nurses. 53.2% reported that the nurses always listened carefully. 58% said that the doctors always listened carefully. And majority of the patients, 52.4%, reported that the nurse explained things so that they could understand. About medications, 83% of participants stated that doctors and nurses asked questions about the medications that they were taking from home. The majority of them, 63%, stated that they did receive medication in the emergency room. However, 75% reported that side effects were not explained to them. The majority of patients reported that the medications that they were given to take home were not explained to, they were given medications to take home, but 95% said that they knew and it was explained to them what the medication was for. About follow-up, 53% stated that they were not provided with information about symptoms or health problems to watch out for at home. And 22% of respondents indicated that they did not receive information about follow-up care. The overall experience in the emergency rooms were rated from 0 to 100, with 21.7% awarding the emergency rooms a 10 out of 10. 21% of participants rated their experience at 9, and the lowest possible score that could be achieved, one respondent gave a 1 out of 10. And we saw that there was no relation between the hospitals, the different hospitals, and the different scorings that were done. 78% of individuals said that they would definitely recommend the services of our Type A hospitals emergency room, and for Cornwall Regional Hospitals, 78% would recommend, as well as 76% from KPH said that they would recommend. So, even although we would have presented previously that persons in media would have spoken about the dissatisfaction of our citizens with the services that we provide, our study has proven contrary, as 78% overall satisfaction among participants was determined. And we know that in analysis of getting timely care, there was a significant difference between the mean scores between males and females, which suggests that there was some association with gender and their perceptions of receiving timely care. There was no statistical significance between patient satisfaction among the responses, as I said, from each hospital. The strengths, the study of this kind is first in Jamaica, and we think that we could do other qualitative analysis to determine whether or not the results are actually significant in terms of, are we just used to this level of service, or can we be exposed to other things in the future? And it can also help to develop how we provide care. Limitations, we only focused on Type A hospitals in this study, so we could broaden the horizon, as well as there was a predominant high level of education, with majority of persons having high school or higher level of education participating. In conclusion, patients who visit the accident and emergency departments of Type A hospitals in Jamaica gave a general high rating for their overall experience, and there is an appreciation for the current provision of services and the information given regarding follow-up and medications. Patients' communication with doctors and nurses is considered to be effective, and there is a significant dissatisfaction with wait times spent in these departments, mostly in excess of 6 hours. Here are our authors, and thank you.
Thank you, Ms. Jenny Linton. Very important presentation, because so many times we just focus on the numbers going through, but we need to know how patients are perceiving what we are providing. And it's good to hear that overall satisfaction is quite great. You know, we are doing some things right. Any questions?
Much for your excellent presentations. For the Mrs. Smith online.
Right on Smith, yes.
Yes, Mrs. Smith online.
Still online?
Yes, she's there.
I am here.
Yes, she's here.
Question for you.
I can see, so she can see me. So the question I have there, where the doctors for mental health are being regarded, I use the word as maybe looked down on, as not as qualified as the other physician, or rather maybe they are insane because they're going to take care of mad people. So what do you think? Because you see the brain, we can't see our brain. We can see our eyes, we can see the skin, we can see everywhere else. And then if there's any little blemish, you want to rub it off, you want to take care of it. But the brain, you can see. So do you think if we have a way of ensuring that the brain is assessed, you know, you have a way of looking at your brains and know what is happening to you, you might be able to appreciate those who are indeed taking care of our mental health. Do you think that will be a plus?
Thank you for your question. I think, well, there are other studies in Jamaica that has shown that mental health literacy is very low. I don't know. Okay, yeah. That mental health literacy is generally low, and that's not only among the general population, but even among professionals. And that, I think, contributes a lot to the perception of psychiatrists. One psychiatrist described psychiatry as the ugly stepsister, which I thought was such an interesting way to describe it. That they're given the rooms at the back of the health center, and they're seen, you know. So she was just trying to show that throughout there is this sense of, if you're doing this, you know, you're less than. And we have to do a lot more to educate people about the seriousness of mental illness. As a global problem, it continues to grow, and it's becoming more formidable because we're reluctant to address and recognize the need to see this as a central part of care and health care. So yeah, we definitely need to put more focus in this area.
Okay, so it will be better if I see my brain just like I see my eyes and my skin. Good. Now the next question for the last presenter. Can you just tell me what is type A hospital?
What are type A hospitals?
Yes, like I keep hearing that. I hear type A, B, C. Yes.
Oh,
maybe
so
there's somebody who don't understand, like me.
There are different classification of hospitals in Jamaica. Type A facilities are the ones that offer the majority of services in terms of surgical and referral in ICU and other severe health services for Jamaica. So Cornwall Regional, that is able to provide service to all the specialties, including surgery, ICU, having outpatient clinics, and so on. They're able to operate as type A facilities.
Okay, so is there a case where government can deliberately improve a type C to a type A?
Is there a case where?
Yeah, can it be done because you want to ensure that person? Because I know that persons are referred from probably somewhere to UWI or to KPH.
Persons are referred. You're asking if they're referred or we can upgrade?
No. Can we take a type C to a type A? If you want to give a better healthcare, instead of somebody traveling all the way from type C to come to a type A because of the level of care that is being offered.
I understand. So the services at a type C hospital would have to be upgraded as well. So we would have to ensure that the facilities are upgraded to meet the needs of the patients, including not only infrastructure, but the medical knowledge and the medical services of the personnel there, in order for it to be upgraded. Because of monetary constraints or whatever the reason is within Jamaica, we have specific hospitals at this time that provide that service.
Okay, thank you. The last question. Now, the result you got is different from what we were expecting.
Truly.
All right. Now, can it be reproducible?
Can it be reproducible? I think so, because even while we were there, even on a qualitative basis, speaking with the patients there, you would understand from them that they're willing to wait. They're willing to be there, and they have made up their mind that once they're coming, one thing they're guaranteed of is that they will receive an answer for the question that they have. So irrespective of the fact that they complain about the wait times, or might say sometimes that they are unfairly treated, what they leave with at the end of the day is that the answer that they went for, the situation that they went for, was answered and resolved.
Okay, so
I do think it is repeatable.
It is because I was just going to say to you, probably it was the group of people you met on those particular days.
It's not because I'm nice.
Okay, so, or rather because I've been hearing a lot from different persons. So I will be glad if we can repeat it. Since it's the first of its kind,
yes.
So I'm going to encourage researchers in the room and those online
as well,
and go check how you can do more and check different groups of people, and let's find out if we can maintain these very same
we
results.
Can still improve, because they're waiting 6 hours and more, so we can still improve.
Definitely.
But yes,
all right. Thank you.
I think so.
Yeah, just good afternoon. Just following on that question Dr. Alonge asked, with regards to the results that you got, were you surprised that there was no difference between all three hospitals? Because
were we surprised that there was no difference in terms of the satisfaction levels?
Yeah, the satisfaction levels.
Not entirely. Why? Because we recognize that there is a certain cohort of patients that go to UE versus KPH, and everyone knows what they're looking for at that particular institution. So irrespective of the fact that we went to the 3 locations, persons have now become acclimatized as to what to expect, and we were not surprised that the results were not different. We did anticipate some level of skewness at KPH. However, then I must say, we were pleasantly surprised there, because nobody was complaining about their level of satisfaction there. Persons reported that they were indeed satisfied.
Okay, thank you.
Good afternoon. I am a visitor, but I'm just curious. What type would you call Spanish Town Hospital?
Is it? No, it's not B? B.
Oh, B. Okay.
Thank you.
Dr. Coburn? Oh, sorry. Yes, Dr. Coburn, we're going to read some comments from the chat, and persons are saying, excellent presentation, ladies, and quite a few persons have indicated that these presentations were great. We have learned a lot, and you guys are doing very well. So excellent presentations from this group of ladies. Oh, we do have one more question.
Just before Muzaz asks this question, I need to make a comment because of the whole, especially on Ms. White-on-Smith's presentation, because it really speaks to what we are trying to do in the Ministry of Health in trying to see how we can make sure not only to our mental health patients that their curative conditions like high blood pressure, diabetes taken care of, but also to recognize that sometimes persons who have non-communicable diseases in the curative clinics, sometimes they are depressed. So they have anxiety problem, and that affects adherence. So we want to not only increase the mental health professionals, make sure they look out for the non-communicable disease, but also that the non-communicable disease physicians also look out for the mental health issues which can complicate the outcome of their treatment of patients who have other non-communicable disease. Dr. Muzazi, your question or comment?
Yes, just a quick comment to point out that interestingly, a 6-hour waiting time for non-ambulant patients at accident and emergency is actually within the global time range. It's not too far, which is what I found interesting. And of course, as our minister likes to say, patients come to the clinics not to necessarily get well, but to feel well, which is a difference.
Yes, yes.
Thank you.
Yes, thank you, Muzazi, for your comments. And then my last point is the importance of how we relate to our patients. And that's where an important part of our, what we call mental health gap action program is really essential care of practice, which we think all physicians, all nurses should display when they are interacting with their patients. So have empathic communication, caring attitude towards the patient, because you may be very knowledgeable, but if you don't have the right attitude towards the patient, then therapeutic alliance will not be there and the outcome will be negative. So thank you all, presenters, for your well presentation. Please give a round of applause for their excellent presentations.
And once again, we want to recognize our moderator as well, Dr. Goldburn, and we want to thank him for ably taking us through this session. So thank you once again, Dr. Goldburn, and thank you to our excellent presenters. So I'll just invite you all to stand down and take your seats. And we won't take a break. I'll just go into the closing remarks. We really have to give thanks, even though we have not reached the end of the 3-day sessions. But in reflecting, we have come to the end of 2 days of 21 oral presentations. Today we had a special presentation from our permanent secretary, followed by presentations on the applications of technology in public health. We also had our scientific presentations, which covered laboratory studies, the impact of communicable diseases, reproductive studies, and social support and mental health. As a reminder regarding a few housekeeping matters, we remind you to explore our virtual platform. You have one more day, so one more day to get yourself on the leaderboard for your prizes and surprises. Please join us tomorrow, where we will have panel discussions and special presentations on a number of areas. These include reproductive health and pregnancy in older women, reproductive health and environmental pollutants, sessions on communication for researchers, healthy eating and you, backyard gardening, and reasoning on the wellness bench. Our final session after lunch tomorrow will be on telemedicine and ethics. So you will see that we still have a feast in store. We will also be showcasing our poster and oral presentation award winners. So we ask you to join us in the afternoon tomorrow. We continue to give thanks for an excellent day, and we wish you a good afternoon.